I wanted to just congratulate each and every one of you and to thank you for all your hard work. So I have a small gift at the back. Every bag has your name on it with my signature red pen. So you'll remember me. So you can grab them at the end of the presentations. I'll be in and out today because I have to sign out reports for her. But right?
Right.
So, but I'll try to see as many of the presentations as I can, and I'll be late to the party tonight. But congratulations to everyone, and thank you.
And what makes our internship so strong is we have so many committed mentors like Ron. Ron, we appreciate all that you do for all of the interns coming and going and ongoing, which is really wonderful. And I want to, not all of the people who are the mentors, raise your hands here. That's you over there too, Susie, up there. So it is, this program could not function without all of the help and support that we have. We appreciate all of our mentors, and Jeff and I really appreciate Francesca and Anne Marie and all the work that they're doing. And we are just super excited to see the final result for today. We have, we're going to have a couple of things on video. We'll have a couple of stand-ins because some people have fallen ill, but that's what we do. We are nothing if not adaptive. Okay, so without further ado, congratulations to our graduating class. A couple of you will be staying, thank goodness. But we're going to start with our presentations, and Maya is going to start us off. And Maya, I'm giving Maya a little extra time to actually do an overview of the I-SPY 2 trial so that you can understand the presentations. So the interns, when you start, you're going to say the most important thing I learned this year and where you're going to be next year. And then you get to start, and each person is going to introduce the next person coming, or I'll come up and introduce each person, but that way we want to have a transition so that people understand that every project we do is connected. And just to remember that in my opinion, the most important thing that you all are learning this year is to listen to your patients, to make sure that you are patient-centered and what you're thinking about and how you learn to care for people and how you learn to design trials is with the person in mind for whom the treatment and the trials are for, and to learn to work in teams. It's not all about you. It's not about you. It's about making a difference for your patients and making their lives better. I don't know if Amy Babel is on our video, but we'll keep an eye out for her. This internship program actually has been endowed by her. And this leadership fund, we're actually working on a fun new name for the internship program. We might call it the Babel Leadership Fellowship. And all ideas are welcome. We'll talk about it at the party tonight. So without further ado, Maya.
Hi, everyone. My name is Maya. Hello, everyone. My name is Maya. We're all right. I'll do that. So I'm actually going to say what I learned in my presentation part because I have a slide for it. So I'll just start with introducing myself. My name is Maya, and I am currently a I-SPY intern at the BCC. I am going to start with a bit of an introduction to the I-SPY 2.2 trial, as a lot of the talks you'll hear today are related to this trial. So I want to give an overview so that you guys have a bit of an understanding before we get into all of the projects. So to begin, I'm going to give a bit of context into the I-SPY 2 trial, which was the predecessor to the I-SPY 2.2 trial, which is currently happening. So I-SPY 2 was a trial that gave patients neoadjuvant treatment for molecularly high-risk stage 2 to 3 breast cancer. The overall goal of the trial was to, instead of do what is traditionally done for breast cancer, which is have patients get surgery and then get chemotherapy after, This trial gave patients chemotherapy first, and then after the chemotherapy, patients went to surgery. So you'll see at the bottom, there's sort of a graphic of the I-SPY 2 trial. Patients would get an experimental arm, paclitaxel with a novel agent combination, followed by AC, and then going to surgery. And patients also got MRIs and biopsies and blood draws throughout the trial as well. The I-SPY 2 trial was sort of an archetype of the adaptive platform trial model. This means that as a platform trial, unlike traditional clinical trials that usually have one drug involved, the I-SPY 2 trial was able to have multiple arms of experimental drugs that would move through the trial, leave the trial, and also you could add new arms and new drugs to the trial. This allowed treatment to be more adaptive to patients' needs, and also just gave patients more options in general. So I-SPY 2 was sort of the archetype of this new, better type of trial for patients. Since 2010, when I-SPY 2 began, 23 agents or combinations of agents with control arm evaluated over 2,000 patients. 10 of those agents graduated, which meant that they had an 85% probability of success in a confirmatory phase 3 trial. All right, so moving on to I-SPY 2.2, this trial uses a sequential multiple assignment randomized trial, or SMART design. The overall goal is to maximize the chance of reaching PCR for each patient, pathological complete response, which means that at the point of surgery, there is no cancer left in the patient. The key features of this trial is having a patient-friendly design. This is done by having investigational agents in the first treatment block, block A, followed by allowing patients to have additional shots on goal after having had subtype matched treatments. So block A is the experimental arm. Then patients can get a block B, which is still subtype matched, followed by block C, and they get additional shots on goal after block A or after block B, where they can potentially go to surgery. So they're able to skip block B and C or skip just block C, which minimizes toxicity overall due to unnecessary treatments. In addition, halfway through block A and halfway through block B, if treatments are not working as well as we want them to be, patients have the option of early escalating to the next block of treatment, which ensures that if that they don't get extra treatment that isn't working for them. So again, that minimizes toxicity due to unnecessary treatments. All right, so de-escalation or going to surgery early is based on a predicted residual cancer burden algorithm. So in order to decide whether patients have this opportunity to go to surgery, we put them through this algorithm that predicts whether or not the patients have a high predicted likelihood of having pathologic complete response. This is determined using the MRI functional tumor volume at baseline, 3 and 12 weeks, along with the results of a core biopsy of their tumor bed at 12 weeks. If a patient's predicted probability of pathologic complete response in a subtype specific FTV model is less than a threshold, and the patient has no invasive cancer on their biopsy, then they are given the option to de-escalate or go to surgery. And here you can see an example of a patient who had a tumor at baseline, and by the time they were at 12 weeks, the tumor was gone and the patient was offered the opportunity to go to surgery. So the response predictive subtypes are new subtypes used on the I-SPY 2.2 trial that were developed by data from 990 I-SPY 2 patients across 9 different arms. These new subtypes reflect different predicted sensitivity to immune, DNA damage repair deficiency, and HER2 targeting agents. And as I said, they are now used to inform I-SPY 2.2 block B agent drug assignments and randomizations in block A. So as you can see, with normal receptor subtypes or the regular receptor subtypes that were used on I-SPY 2, you can see that about a third of the hormone positive, HER2 negative patients are actually immune positive. So they could potentially benefit from having immunotherapy. Similarly, for triple negative patients, about a third of those might also benefit from immunotherapy. And about a third of the triple negative patients are also in this category that are positive for DNA damage repair deficiencies. So in general, through this new creation of response predictive subtypes in I-SPY 2.2, we can better understand patients' tumors and give them treatment that is better suited to treating their tumors. So some innovations that I-SPY 2 was a part of are that the trial makes treatment more efficient and fast for patients. Through qualification and validation of new biomarkers, in addition to pathologic complete response and residual cancer burden, the I-SPY 2.2 trial and I-SPY 2 trial learned as we went in terms of figuring out what's best for these patients. Lastly, I-SPY 2 has a really patient-centered design. So we gave patients the opportunity to tailor treatment based on their response, and overall burden of treatment was reduced in the setting of both good response and poor response. In addition, you can see an image of a tool that we are developing to be able to consent patients virtually. We can send these videos to patients so that they can learn about the trial before they even go into the clinic. So how good is our early endpoint, pathologic complete response, aka having no tumor left after surgery? So the I-SPY 2 trial data is seen here. Patients that did not have a pathologic complete response have a much lower event-free survival than patients that do have a pathologic complete response. This means that patients that did not have a PCR were more likely to have recurrence than patients that did not. So overall, if a treatment is less toxic but has the same efficacy, it should be considered superior, not non-inferior to the traditional standard of care. Lower toxicity enables superiority if we use an combined endpoint of efficacy and toxicity. For this reason, I-SPY 2 includes quality of life measures so that the endpoint can include both efficacy and toxicity measurements. And last but not least, this trial has many sites all across the nation, which allows us to reach a large patient population and a very diverse patient population. That's all I have on I-SPY. All right, so now I'll begin my presentation, my project. So to start, one lesson I learned from the BCC is that clinical trials can be flexible. I think most people, when they think of clinical trials, think of very rigid protocols that cannot be changed. But I-SPY 2.2 is really different because the protocol is changed in response to what patients need. And so I feel very privileged to have been able to work on a trial that really caters itself to patients. And I've been able to directly see how that catering to patients has positively impacted my patients' care. So it's a great lesson. Did I mention where I was going to school? Okay, so I will be here next year for school at Parnassus. So yay, medical school, if that's not obvious. Yeah, so my project for this internship was patient attitudes towards de-escalation on the I-SPY clinical trial. So I did just talk about this, but I'm going to give another overview. What is de-escalation? De-escalation is getting surgery after only 1 or 2 blocks of treatment. So after just having block A or just having block A and B. And whether or not a patient can de-escalate is determined by their MRI results and their biopsy results at the end of either block A or block B. All right, so why do we care about patient attitudes? Well, the official study objective is to understand current patient attitudes and levels of interest in de-escalation, as well as perceived barriers and facilitators in pursuing the treatment de-escalation pathway, just in general, to be able to make this de-escalation time point better. But we also care because patients want a voice in their treatment. A survey that I did as part of this project showed that patients really prefer to be involved in decision-making, and deciding whether or not to go to surgery is a big decision. So we want to hear their feedback regarding this very important time point. So the study design is 15 to 30-minute qualitative semi-structured interviews with patients both before and after their de-escalation time point. We interviewed a total of 20 patients, and 19 of those patients submitted a 5-minute quantitative survey as well, from which I got all this demographic data. So we interviewed a wide age range, race range, et cetera, for this study. So the major categories of the results of this study are, first of all, how do patients feel about going to surgery or de-escalating? How do patients feel about continuing treatment or not de-escalating? And what barriers and challenges did patients report regarding de-escalation? So I'm going to go through all of these questions and some themes that came up throughout the interviews. So how did patients feel regarding de-escalation or going to surgery? So some patients were really happy about it. They felt that de-escalating would minimize their side effects. If they didn't have to get extra chemo, they wouldn't have the side effects that go along with chemo. Other patients felt less excited about it. They had some concern over not doing extra treatment might cause greater recurrence in the future. Some patients were more excited about it in that they really wanted to get surgery. So this patient specifically is saying, I'm adamant that I want surgery. I don't want the next round of chemo. So there were both positive and negative emotions for these patients that came up throughout these interviews associated with de-escalation. And the last theme I want to talk about is expectations of patients going into the de-escalation time point. So as shown from this quote, a lot of patients' expectations were formed by the MRIs that they have gotten throughout the trial before coming to the de-escalation time point. So this patient in particular, after she got the second scan, her second MRI, and saw reduction, she started expecting that she would go to surgery at this time point. So now I want to talk about how patients felt about continuing treatment and not going to surgery. So some of the big themes that came up was, again, concern over side effects. So patients sometimes felt negatively about going to continue chemo because they would have side effects. And some patients did experience a lot of disappointment because they had expected that the first block of treatment would take care of their cancer. And then this patient in particular, when she realized she only had standard of care form of chemotherapy left, she was apprehensive. So some patients, though, had more positive reactions to not going to surgery. This patient and other patients were just willing to do whatever it took in order to get to the endpoint and achieve success. And other patients felt that they gained more security by doing more treatment. So this patient felt that it gave her more peace of mind, and that getting the standard of care that is tried and true and works for her tumor makes her feel more secure in her prognosis and her treatment. All right, so the last category I want to talk about is challenges that patients faced throughout this time point. So one of the challenges that came up was having a lack of information. So some patients felt that they did not have enough information regarding the next steps of their treatment or going into the time point, exactly what had happened to their tumor. This patient in particular suggested that a deeper and more detailed return of results that included more about interim progress and treatment plan would have been helpful. Another challenge that came up was communication in general. For some patients, there was a very abrupt notification and they didn't feel like they had enough communication about the fact that they were going to change their treatment plan or they were going to surgery. And this is just one example. And I do want to say, a lot of patients also said communication was great. So it was very dependent on the patient. And then lastly, some patients felt that they didn't have enough communication with other patients on the trial or patients that had been on the trial formerly. So this patient suggested that it would be helpful to have a support group or something of other people in the trial just to understand how, I think that's supposed to say, everyone else is doing and how everyone else is faring. So based on these challenges, I came up with two main recommendations. One would be to add more detail to the return of results letters. A lot of patients just talked about wanting more information about how their specific tumor had shrunk, and maybe more detail about the drugs that were coming up. And then another recommendation would be to improve access to patient support groups, because I'm pretty sure there is a patient support group, but as far as I know, and my experience with what the CRCs on this trial know, there's no necessarily like link or direct contact that we can just give to patients whenever they ask, oh, is there a patient support group we can talk to? So maybe through the iSpy website, having pamphlets that we are allowed to give to patients, or having even a person who is a point of contact that the CRCs can get in contact with regarding patient support groups would be a good idea. So next steps for this are to, one, interview providers regarding de-escalation to get the provider point of view as well. Two, to code all the interviews using at least 2 coders, which is recommended for any publication. And hopefully one of those coders would have more experience doing qualitative data. And lastly would be to write up the results for publication. Thank you guys so much. And I'd like to give special thanks to Rachel, Dr. Esterman, Dr. Roque, and Safi. And I forgot to add them, but Eben and Sarah, who are former interns, did a lot of work on this too. So thank you.
Jeff, we ought to be able to do AI to do the interviews of the physicians, right? So they don't, and then the coding can be automated, right? Let's get, who are our AI people? You'll work on that. Okay. So how about, I mean, obviously this is really important. From looking at these interviews, and I see it was a pretty well-educated group of patients, and obviously the physicians are there to fill some things in. But what would you think in terms, I think expectations was one of the things that you brought up. Mm-hmm. So just given that not everybody gets, you hope everyone will get the good results, and it's always, I would say it's always easy to adjust to good news and harder to adjust to bad news, right?
Absolutely.
And so what would you recommend, you and Gabriella, how would you recommend that incorporating what you've learned into telling people about the study to begin with, or maybe even putting into our virtual informed consent?
That's a great question. I think on one hand, you can never ensure that patients feel happy about whatever their treatment ends up being. I think at the beginning also, it's really hard to know what is going to happen, because as I said in the presentation, a lot of patients' expectations change as they get the results of their MRIs, as they talk more with providers. But I think it is helpful at the beginning, sort of when they're consenting, to not overpromise. Yeah, to set expectations to that, it might not work. And I think from my experience with the interviews too, patients that said that their providers were more hesitant to overpromise. And I had patients say, oh, well, I didn't, like, my provider was really hesitant to tell me I was going to go to surgery or to be as excited as I was. Those patients ended up feeling better overall, because if they do end up going to surgery, they're happy. And if they don't end up going to surgery, they're saying, oh, well, my doctor did warn me about this, and like they were hesitant, so I was a little bit more prepared. So it's hard to do that at the beginning, at the informed consent part. But I think it's something that providers sort of need to do throughout the whole process, because it's a long process, right? It's like right, so up to 9 months. So, but providers do a really good job of this a lot of the time. But of course, not every
Here's-
patient is going to be perfect, or not every
We're
provider
not
is going
gonna
to be
hear
perfect.
what they want to hear.
Yeah, exactly.
Other questions that people had? I see a hand up here. Yeah, I think these, it's very interesting because these are qualitative interviews, but super informative. And I think this is really some training or education that we can give. We hope that you'll come to Rachel can organize for you to present this at one of our 2.2 meetings when we can get Gabriella on, and that we can really, we don't have a support group for the de-escalation process. We can talk to Jane Perlmutter about that and think about it. But in some ways, as we're actively informing patients as they go, this is so untraditional in trials that we're going to run up. For sure, I serve on the Blue Cross Blue Shield Medical Advisory Panel, which I think is my punishment for trying to move the field forward. But that's an extremely conservative group of people. This is the group that decides whether insurance should pay for new approaches, new drugs on the basis of trials. And they would reject what we do because it's open label. We're giving people information as they go, changing expectations. So it's something we should really all think about. That's an important part of moving the field forward, is sort of preparing people for a new way of thinking in a way that is perhaps less threatening. But I think these qualitative interviews will make a big difference in helping us. So fantastic work. Thank you so much for finishing that first part of the study, a 3-intern project. Okay, next, we have Molly Baxter, right? And so one of the important things is, if someone really does have a good response, can we safely do less in terms of surgery? And she's going to tell you about her project and why it's important and what she learned and where she's going.
I'm Molly. One thing that I learned at the BCC is that assuming that your vision is possible is half the battle. And then once you know that, you can do basically anything. And that's why everyone should come to Rise Up, because it is happening, because we just decided. And next year I will be going to med school at Johns Hopkins. So my project for the internship that I've been working on with mainly Annie Tang, but also Dr. Price and Dr. Esterman, is about residual microcalcifications after neoadjuvant therapy and whether or not we need to go back and take those out. As Dr. Esterman mentioned, we really want to do as much de-escalation as possible and avoid unnecessary overtreatment that often is sort of the standard of care, that our safe than sorry approach. And so I looked into whether you always have to be better safe than sorry, or you can just trust that your information is enough, and it worked. Okay, so microcalcifications are just these little white specks that show up on mammogram. Mostly they're benign. Sometimes they're cancer, depends on the pattern. But it's not necessarily a bad thing to have on your mammogram. And you have these examples of the way that they could appear. And then the current standard of care is, if you have calcifications on mammogram, you get a rating of BI-RADS 6, which is this bottom one here. And then the standard of care would be to go back in after your initial surgery. Right. Yeah. This is after surgery. You would go back in and biopsy those calcifications, and maybe even go back in and do additional surgery, which often turns a lumpectomy into a mastectomy, which is obviously not what the patient wanted in the first place. And the other thing about this standard of care is that it's enormously stressful physically and emotionally for the patient. It's obviously really upsetting if you were told you had a good response, and then you get your post-surgery mammogram and they tell you, actually, I do have cancer again. And you're like, what do you mean? You told me I was fine, and now I have cancer again. It didn't work. It's very upsetting. And then you go back in, you have more surgery. Obviously, that's also not ideal. And so the solution to changing the standard of care is to incorporate residual cancer burden, which Maya mentioned in her presentation, and I will get into a little bit more. So it's a tool to calculate how much cancer is left and sort of associate the risk of local recurrence. So you can see if you have RCB0, which is also pathologic complete response, you have no tumor left. and the local recurrence rate is very, very low, 1.5 or 2% at 3.5 years. And even RCB1, which just means like a very little amount of cancer is left, has a 4 or 4.5% risk of recurrence. So very good. If you have PCR or RCB1, your outcome is probably pretty good. And by incorporating that and using that as our main tool rather than relying only on the calcifications, we're able to be a little bit more tailored in our course of treatment. So now I'm going to tell you sort of a choose your own adventure story. So this is a patient, and on the right is the initial mammogram, the pre-surgery mammogram, and you can see there's tons of calcifications in the breast. And then on the left, those are the samples for pathology that they were removed during the lumpectomy. And you can see lots of calcifications removed as well. Those were all benign on pathology. But sort of the two directions that this patient could go, when you look at the post-surgical mammograms, where you can still see those little white lines are the calcifications. So there were still calcifications. Obviously, they look different and there are fewer of them, but they're still there. And with the old standard of care, this patient would be told, you still, have cancer. You need to go back in. We need to biopsy those. We need to possibly do more surgery. But with the new standard of care that we're proposing, and actually this is what was used on this patient, which is awesome. Surveillance is probably sufficient in the case of PCR, which this patient had, and you can rely on the PCR and say, there was no tumor, they had a complete response. These calcifications are more than likely benign and we'll keep an eye on them, but we don't need to go back in and do more unnecessary procedures unless something else indicates that that's necessary. So that's very exciting. But obviously the other side of the story that could have happened is just like enormously upsetting and confusing for the patient and something that we're trying to avoid if at all. So what I did was a retrospective cohort study of the I-SPY 2 patients for the past 13 years. And so you can see we divided it out. We looked only at patients with PCR or RCB1, so complete response or very, very little cancer left. There were 294 who had calcifications, and 106 of those had PCR. And our hypothesis was that not all of these residual calcifications were going to be associated with invasive disease or even with DCIS, and that not all residual calcifications required resection. And then specifically, we were thinking in the context of PCR, you probably don't need to go back and take the calcifications out. They're probably fine. So the first thing that we did was we looked at all the patients and just divided out by PCR and RCB1 just to see what we are working with. So this is patients who had any type of surgery. And we found, you can see that the blue on these graphs is for benign calcifications, the pink is associated with DCIS, and the gray is associated with invasive cancer. So for patients with RCB1, there were some patients whose calcifications probably indicated that there's still cancer and that they should probably go back in and biopsy or re-excise them. But you can still see the vast majority is DCIS or benign, with the majority being benign. And then for patients who had PCR, you can see overwhelmingly they were benign calcifications. 12% were associated with DCIS, which again is not invasive cancer. So our preliminary conclusion, we're thinking probably most residual calcifications after neoadjuvant therapy can be safely left in the breast if the patient has PCR at surgery. So then what we did to sort of confirm and elaborate on those findings was we looked at only patients who had mastectomies, because that sort of is its own self-contained experimental approach, because there's nothing left in the breast. So you can look at what came out in the mastectomy and that's everything that was there. So there's no mystery, right? With the lumpectomy, you're wondering, maybe we just didn't look, maybe there's something in another area that we didn't see. But with mastectomy, you're able to be certain of what you found and what was there to begin with. So we broke it down by calcifications. There were 21 patients who had calcifications on mammogram pre-surgery. And of those patients at pathology, the calcifications, 13 were associated with not invasive cancer or DCIS. They were completely benign. And then 8 of them were associated with DCIS. Again, nobody had calcifications associated with invasive cancer if they had PCR. So that's very promising as well. It's just a reiteration of what we found with the larger group, but sort of confirming, because there's no mystery with the mastectomy. There's like no question lingering about what we might have left behind. So we have about 68% benign calcifications if you had a mastectomy and you had PCR at surgery. So the next steps for this project, obviously we want to go back in and look at the lumpectomy group and see how that is different from the mastectomy group, whether that's going to confirm our findings, and specifically look at the post-surgical outcomes. Right, so we want to see like how many of these patients actually had their calcifications biopsied, how many of them actually went in for additional surgery, and what did they find when they did that, to try and get a little bit more of a complete picture of what's going on. And then the other thing that we want to do is we want to now look at patients who had RCB1 and see whether there are things that we can learn from that to say those are probably also fine to leave in. And we're wondering specifically, is it okay if you had RCB1 and you have some calcifications, can you just radiate and do surveillance and not go back in and do additional surgery? And we're thinking probably that's the case, but obviously we need to confirm and get the data to support that. And then eventually we would like to change the BI-RADS classification so that patients with residual microcalcifications in certain contexts, probably PCR, maybe even RCB1, would not be assigned such a high BI-RADS classification, which would avoid a lot of stress for the patient and also allow the doctor to sort of step back and trust that they're doing enough and not worry that they should have been safe rather than sorry. So, yeah. Thank you very much to Dr. Tang, Dr. Price, Dr. Ali, who I inherited this project from, Dr. Makhtar, and Dr. Esami.
Great job. And I know Susie in particular knows what a huge issue this is in the clinic. So my question is, even the patients that had DCIS, were all the calcifications associated with DCIS, or was there also benign, and was the DCIS a major or a minor component?
The DCIS was a minor component, and they were also associated with benign ducts on almost all the cases.
Laura.
As I'm representing molecular subtypes here. So my question to you is, I have like no idea. Is it known whether calcifications are more frequent in women's breast where a hormone receptor positive breast cancer occurred or triple negative? And if we then look into I-SPY, since we're looking deeper in the biology, whether there's an immune sensitive biology or others, that might be something.
It's a good idea. We haven't done that. My experience is that, calcifications show up. They can be, be benign DCIS. They can be DCIS. They're probably different, but I think they're different patterns. They probably are subtype specific. I think that's super interesting. That's fun. New interns, interesting project and very simple to do because all these patients are on I-SPY.
It could lead to nothing, but sometimes I like to see those things because then I can sort of put it to rest and think, okay, nothing. But if it is something, we can think about it, what it means or what do we do?
I don't see Ron here, but I mean, the part of the problem is the calcifications are a footprint, right? They're not the tumor themselves. They're just the precipitation of calcium from dying cells. So when you get rid of the tumor, calcifications don't go away. We do know from our DCIS project that they'll eventually, sometimes, but not always, go away. And the question is, it's these rules that we have that are way old, 20 years old, force people to do things that probably have no value and frighten them a lot. Right.
What we could look at, because there are people have now been looking at sort of initial biological changes in the breast epithelium, so just the duct lining, and you can see that sort of the initial changes are actually present in a large extension into the ducts, right? So even though you have removed the tumor, there are certain ducts associated with that area that have similar initial changes there, which by themselves are no cancer whatsoever. Anyway, we can look at it.
And I think the opportunity, you showed this at the beginning, right? So we have, even in our lumpectomy or RCB1 cases, where, not all the calcifications were necessarily removed. We have outcome data, right? And that shows what?
The outcomes are really good.
Yeah. If you have a good response, your outcome is really driven by your response to treatment. And this is sort of, again, one of my favorite terms, misplaced precision. So, you'll hear in tumor board people going, to town or going crazy over every last calcification, every last detail, which that's actually no longer the point, so. Get a mic so we can hear you.
To Laura's point about calcifications, as you say, as being the debris of dying cells, right? There's obviously a phenotype there even at the beginning, right? With calcifications on presentation. So I think it is nice. It would be a good project to do.
Well, I think it would be a very fun project to look at the type of calcifications. I mean, the example you showed, that's never a situation. Those calcifications are never good to have on your mammogram. I've never seen a situation when those calcifications are benign. So there are different types of calcifications. So we could definitely look at that, and that's a great idea. So I don't know who's going to pick this project up, but hopefully somebody. That's great. Okay, fantastic. Okay, so Hannah is joining us from her quarantine on Zoom. Typhoid Mary. How are you feeling, Hannah? Are you all better?
Oh yeah, I'm feeling great now, but thank you for asking, Dr. Esterman.
All right. Okay, fantastic. All right, so we're moving right along, and Hannah has some really, you'll sort of understand now. This is another important part of, I-SPY is a big trial that has many interesting facets, and Hannah's going to talk to us about chronic illness after she tells us where she's going and what she learned this year. Most important.
Perfect. So I'll just start by sharing my slides, and then I will share where I'm going and what I've learned. Hi, everyone. My name is Hannah. I am going to UCSF next year for medical school, so I'm very excited to be staying in the city. And one thing that I learned by working here at the Breast Care Center is to never be afraid to ask questions or reach out to your mentors. Everything is a learning opportunity, and there are so many things that you can learn and experience here. So with that, I will be presenting my final presentation on the functional assessment of cancer therapy item GP5, otherwise referred to as the FACT-GP5, and its ability to assess treatment toxicity and quality of life within the scope of clinical trials. Earlier this morning, you've heard Maya talk about the importance of integrating patient voices into clinical trial management, as well as the importance of quality of life measures within the I-SPY 2 trial in particular. You've also heard Molly talk about how less can be more for patients in the long term as well. And I hope that my presentation on the FACT-GP5 metric serves as a means to kind of bridge those two together. So to begin, I want to give a brief overview on our electronic patient-reported outcomes. These are also referred to as ePROs. And in the I-SPY 2 trial, these are surveys that are sent out to patients weekly to assess how they're doing on treatment. But I quickly want to pause and just ask all of you to think about how many times you've completed surveys that were sent to your inbox. I know for myself that I usually ignore these. And so think about how likely you are to respond if that survey is now 17 pages long. That is the length of our ePROs that we send to our patients. And it can be burdensome to have to complete this survey on a weekly basis. However, the contents of these surveys are essential because they assess 33 different symptoms as well as 8 different quality of life domains. So they're crucial for us to understand how our patients are tolerating their treatment. This is especially necessary for trials like the I-SPY 2 trial, where we're looking at investigational arms and we're not sure how they're going to impact patients' quality of life. So the FACT-GP5 serves as this unique opportunity for us to kind of breach that problem. The FACT-GP5 is a single question measure, which is I am bothered by the side effects of my treatment, and it asks patients to score this on a score of 0 to 4, with 0 being not at all and 4 being very much. Now, what's so exciting about this is that we hope that this single measure serves as an easy means for us to compare tolerability between treatment arms, while also optimizing our surveys, and in doing so, improving the rate of survey completion for our patients. To begin, we wanted to first contextualize what the FACT-GP5 looks like for patients within the I-SPY 2 trial. So we began with 2 objectives. One, is the FACT-GP5 a good summary score for patient well-being? And 2, how well does it reflect symptom burden or quality of life for patients within our cohort? We had different types of data to work with that we will use to accomplish this, including demographic data, the FACT-GP5, PROMIS health measures, which is our quality of life measures, as well as patient and clinician reported adverse events. When I came into this project, my goal was to take the FACT-GP5 and the PROMIS health measures and to develop a workflow to analyze and visualize the PROMIS and the FACT-GP5. So first, I want to start with a brief overview of who is in our I-SPY2 cohort. We had 305 patients for which we had FACT-GP5 data available for. The mean age was around 48, ranging from 20 to 78, and the majority of our participants were white. To begin, I want to present us these figures on the FACT-GP5 alone, and I want to just quickly orient everyone to these figures. So starting with the rows, we have the time points in which patients were asked to fill out the FACT-GP5 in chronological order from top to bottom. So screening at the top with follow-up at the bottom. Each column represents a different drug arm that patients were randomized to on the I-SPY trial. On the leftmost figure, we're looking at the distribution of FACT-GP5 scores ranked by patients on a given drug arm at a given time point. And we can see how these trends change over time by the way that the distributions are skewed. So distributions skewed farther to the right demonstrate that patients are reporting a higher FACT-GP5 score overall. On the right, we have a histogram to show how many patients were reporting a certain FACT-GP5 score at that time point. So we can see whether these skews that we're seeing are influenced by just a single patient or several patients reporting higher scores. And the main takeaway that I want to emphasize here is that the FACT-GP5 provides an easy means for us to visualize the differences between tolerability in our treatment arms. Our next step was to look at the PROMIS quality of life data, and in doing so, we used something that we call PROMIS T-scores. These T-scores range from 0 to 100, and they are averaged at 50, where 50 represents the general population. So if a patient had a PROMIS T-score that was higher than 50, that means they were experiencing that domain higher than the average population, and vice versa for if the score was lower. So for this analysis, what we wanted to try to achieve was to understand whether we can use FACT-GP5 scores during treatment to predict long-term impacts on quality of life. And when I say long-term, I mean, can we assess whether worse tolerability or high toxicity during treatment impacts their quality of life into follow-up? So we performed we did calculate experiment correlations for the FACT-GP5 score at week 12 of treatment in relationship with all the PROMIS domains at follow-up. And what we found was that FACT-GP5 score is a strong predictor for certain quality of life domains, but not all of them. I here want to highlight the domains that stood out. So fatigue, cognitive functioning, social functioning, and physical functioning, with fatigue having a positive correlation with high FACT-GP5 scores, meaning that high toxicity related to a worse or higher levels of fatigue, and then cognitive, social, and physical functioning having a negative correlation with a high FACT-GP5 score, meaning that lower functioning in these domains had a high correlation to a worse tolerability. So from this analysis, we can pull that FACT-GP5 is a strong predictor for certain quality of life domains, such as fatigue, cognitive functioning, physical functioning, and social functioning, but it's not representative of all of our PROMIS domains. For example, we did not see any relationships with depression, anxiety, pain, or sleep quality. So overall, we were able to see that FACT-GP5 allows us to visualize differences in treatment toxicity between our investigational arms. It's also a good predictor for certain quality of life domains, but not all of them. As for our future directions, right now we are working on a paper on the FACT-GP5 within the I-SPY2 cohort. And in this paper, we really hope to outline what a high FACT-GP5 score means in regards to symptom burden and quality of life for patients within the I-SPY2 cohort. We hope that these findings will help us reduce the number of questions that we ask on surveys in hopes of making them shorter and easier to complete for patients, and then also making them more engaging as a whole. So with that, I would like to conclude my presentation. I want to give a special thank you to Amrita, Laura, Anne-Marie, Francesca, Samya, and Christian, as well as the other BCC interns.
Thanks, Hannah. Great job. So would you think that we can get rid of for like fatigue, cognitive functioning, and those that we could take those 3 domains and maybe get rid of them, just use the FACT-GP5 and then use, the patient-facing adverse events and just the FACT-GP5, and maybe you can ask about sleep and pain. Would that be something that maybe this data could help us move forward?
So I think that that is a good long-term goal, but the next step might be shortening the amount of questions that we ask for each of these domains. For example, for our promise section of the questionnaire in the physical function area, we ask 8 questions about physical functioning, but we can reduce this down to 4. So I think a good first step would be to reduce the number of questions we ask in each of these domains, because the FACT-GP5 is a good representation of them, and then to assess from there whether or not we can exclude them entirely and use the FACT-GP5 to see whether patients are presenting symptoms or experiencing worse adverse effects in these domains.
Great idea. And maybe 2 would be even better. Something like that. Questions from the audience? Yes, this is super important work. And, it's interesting. Again, this is the traditionalists don't believe necessarily in qualitative things, not that they don't think quality of life is important, but because we have an open label trial, people think that they're biased and that they'll change. Do you have any ideas for how to counter that, so that someone who's on a novel drug might not report as many symptoms about fatigue or quality of life impact than someone who is on standard therapy? That it's not a real difference, it's just their perceived difference.
So how to counter patients not reporting how they're
Counter
doing on
the
the arm?
perception, counter the perception that there's bias because people know what drug they're on.
I see. I think that that might just be a need for more data. And so by having these surveys completed and by also integrating them within iSpy 2.2 and EOP and recast, we can hope to demonstrate that for patients who are on investigational arms. I know that many of them that I work with, at least on the recast trial, are really eager to demonstrate that these arms, they do work and they can help certain patients. And so I think that in that sense, more data would help that claim.
So importantly, that not everyone who's on an investigational arm has few side effects. So maybe that's a very important thing to show, is that the FACT-GP5 or some of these symptoms are reported, even if they're on investigational agents, right? Like you showed, like on one of those drugs, I think it's 9 or whatever, on that first one, the FACT-GP5 was bad. People did not tolerate that drug very well. That's a good idea. Make sure you include that in your paper. Okay. All right. Fantastic. Any other questions? All right. Well, we hope you tested negative today, so we can see you tonight. If you do, we'll see you tonight.
Thanks, Laura.
All right. So next up is Somi, but Somi is not feeling well, and she is actually at urgent care. So I'm the designated hitter. Somi's been here for 2 years, so she's had an opportunity to really work hard. She also has done an amazing job of moving our pooled analysis from 5,000 patients and 10 sites across Europe and the US, proving that residual cancer burden really is associated with long-term distant recurrence-free survival. So we're very grateful to her for that as well. Great 2 years. Okay, so she chose to really look at the change in biomarker profile after neoadjuvant therapy, and where it's most common and what that impact might be, meaning the HER2 population. So there are a couple of things. As we know, the biomarkers, this is estrogen receptor, progesterone receptor, and HER2. These are the biomarkers that we look for on the cell surface of the on the cell surface that we can actually measure on a pathology slide and what we call H&E or the immunohistochemistry stains. So you can start with one subtype, and over the course of treatment, that can change, and it can change either because, you had mixed types of tumor to begin with, and one type is treated well and the other emerges, or it could be that it's suppressed by the treatment. So these are unknown. Rita, I am presenting for SOMI. I'm not really one of the interns, just so you know. Uh, um, but some patients do switch receptor subtype, and we need to know more about that. We need to know if that means that, that's heterogeneity or plasticity, maybe that's a measure that these tumors are sneaky and able to adjust to their environment and escape a way of escaping their tumors, or maybe it's just transient. So we don't know. So there have been pretty limited studies on this and what that means. So the objectives were trying to first look at how many patients change their biomarker profile after neoadjuvant therapy and what that might mean in terms of outcome or survival. And this was a project done with the surgery working group and the pathologists. And thanks to Rita and Judy Bowie, who are the chairs. And what they found was that there was an 18% biomarker profile change rate. And here's the details, the nitty gritty, as she calls it. So this was a retrospective look, looking at 634 patients on I-SPY that were treated with neoadjuvant therapy at 2 institutions between 2009 and 2022. I assume it was here and UCSD, is that correct? Or Penn, okay. And they use the Fisher-Irwin and t-test to compare the clinical characteristics and look at Cox proportional hazard and the Kaplan-Meier plots. And I am so glad Rita's here because she's going to answer one of the questions that I had. Okay, so they were just looking at all the clinical characteristics of the patients. They weren't particularly different from the group, although it was the unchanged profile was a little less diverse than the group of patients whose biomarker changed, but it wasn't statistically significant. And certainly the stage didn't matter. And the breast cancer subtype, though, did matter, where there was a bigger change in the groups of patients who had HER2 positive biomarkers. And we'll show that a little bit more. The median follow-up was about the same. And it does look like the big change was in not so much in the local recurrence risk, as we've talked about. That's actually turns out to be less important for these patients who are at high risk for distant recurrence, but it did make a difference in the potentially in the distant recurrence, maybe not in all patients, but we'll look at specifically at the subtypes. So this was looking again at the patients who had what their pre was on the left, and the top is the post. And if you're in the middle, that shows that they're concordant. And you can see here, is this showing up? No, up here. Well, it's not showing. Okay, so if you can see right across the middle, everything is concordant. And so if you see more distribution on the top, that there was, and so we actually saw a change in HER2 and a gain of HER2 in the hormone positive patients. And you actually saw a loss of HER2 and hormone positive, and in the and for the HER2 positive or hormone negative, you saw some patients. Where's the other HER2? Yeah, also being triple positive. Where's the triple negatives? And one that are triple negative. There's some that are triple negative. All right, so the conversion to triple negative seems to be more of a concern, whereas if you started out with triple positive and you converted to triple negative, so being hormone positive, HER2 positive, and you wind up being hormone negative and HER2 negative, that is a big risk. As well, if you are hormone positives to start and you develop and you lose that looks bad. Now, this is actually a really important point. We are also treating patients in the hormone with endocrine therapies, selective estrogen receptor degraders, where the expected effect is to make the estrogen receptor degrade. So when those patients go to the OR, they often look triple negative. So it will be extremely important when we publish this data not to confuse the two. So people who wind up with hormone positive disease who then have mostly hormone negative because they have a drug that's specifically targeted for that are different from patients who get chemotherapy that's not targeted against the estrogen receptor. So not to be confused, very important. But this is very, very interesting data. And it's not, again, we don't have a lot of patients, but the fact that there was a big difference, I think, means that we should really do a bigger study across I-SPY. And these are the Kaplan-Meier plots for, these are all of what happened. So these are the designation of the subtypes at the time of diagnosis. And you can see in this group here, the loss. This is a Kaplan-Meier plot. So for people who are not used to seeing a Kaplan-Meier plot, you're looking at time across the x-axis, and you're looking at survival on the y-axis. You want to be on the top. You'd like to be in a straight line where over time, nothing bad happens to you. But the worse the worse outcome is to have those curves go straight down.
Well, in this case, it's not survival, it's persistence of the
No, these Kaplan-Meier, these are survival curves. These are distant recurrence for, this is, I assume, distant recurrence survival, free survival, right? Rita? Yes. Yeah. Yeah, so that's bad. Yeah, it's survival. So I think so, again, showing that again, small numbers, there are 11 patients in this group that switched, but they all did very terribly. So again, I think it tells us that there may be some, plasticity. It may be a marker that the tumors have, that have gained.
Believe that it's just, this is Christina, sorry. So
Okay.
it's a subset of the curves. So basically,
Oh, I see. It's just showing the two.
Yeah, technically there's 4, but there's one that's hiding because it's one single patient, and it's the line that had no event there. I mean,
I see. So you're just
numbers, of course, are
taking
very
your.
small.
I see. So it's because it's small numbers and because they're just two. If you just look at these two groups, it really shows that there is a significant problem. So if you're hormone positive and become triple negative, is that right, Christina?
Yeah, basically, yeah, sorry.
I got it. Yeah, I got it. Yeah.
So the important thing is, like, I think that I have only read this once too, paper wise. So the important thing to note is that the p-value there is a log rank p-value. So what it tells you is that there's separation between any of the curves, right? So if you put all of them together, it's saying that. But you have very small numbers and everything. But the focus,
so it's legit. You're giving it the legit. We could just look at these two and say it's legit to compare them from a statistical standpoint. I'm putting you on the spot. I just saw that 10 minutes ago too.
They're still really small, but like they're at least not in a 1. Okay.
Exactly. See, phone a friend. Okay. So this is the strengths and limitations of this are that it's probably the largest contemporary patient cohort looking at the rates of biomarker profile change. We actually did look at this in I-SPY 1, and the pathologist from UNC wrote this up. Do you remember his name? Last name began with a W, but we should look that paper up. Actually, you went and got the specimens for us when you were a fellow from him. Yes. So anyway, the biomarker profile was reported in a 4x4 array. There was actually a fair amount of data missingness. So the findings do strengthen the rationale to routinely retest biomarker profile in breast cancer patients, which, by the way, is a requirement in I-SPY 2. So if we actually decide to pull all this data from the trial itself, I think I would put that high on the list of the projects in the surgery working group, Rita.
It became a requirement. It has now been introduced.
It became a requirement, I think, in 2017 or 2018. So we should have actually a lot of data. Anyway, so I think that's very exciting. Yes. We'll see if we can answer it for you.
Well, maybe it's an observation, which is if I'm a patient I would look at this data and get very concerned about the accuracy of the pre-test, because I don't know if you guys, again, I'm a health services researcher. I don't know how you're conducting these tests, but what is the sensitivity and specificity, therefore accuracy of the test to begin with? Because if 18% are changing, and the test before really does drive therapy, and some of these outcomes are obviously worse, if you switch, that means we've lost an opportunity to treat.
We'll have
So-
Dr. Vanfier answer that question, but fortunately, we don't rely just on ERP or HER2 testing. We actually do a deep dive. So patients get profiled and we look at their response predictive subtypes. So let's have the mother of the finding of the response predictive subtypes explain her answer. Yes.
I think first of all that receptors change can happen. We know that. So
We
that's not
documented
a
it in
surprise,
iSpy
but
1
I
too,
think
yeah.
it's good to see when does it happen and is it very specific to something. And so in addition, we look at more under the hood, like what is the biology of those tumors as classified by response predictive subtypes. So there we also see changes, which just is happening under the pressure of the treatment.
Therapeutic pressure.
But I think what you're thinking about, should we then do something about it, right? Because maybe it happens and it's just what happens and it's an effect of the treatment, which is good. But if it changes in a way that the tumor becomes to have a worse biology, maybe we should act on it. And so that's actually part of studies going on. What is the longitudinal effect across treatment?
That's one of the goals.
And how should we act based on the biology of the residual disease?
So
Nobody has ever done that, actually.
One of the reasons why we do the biopsies over time is and require the biopsies over time is that we're actually looking for plasticity. We know that heterogeneity to start with is you do worse. And Laura's got a group of people who've done worse. So we should 100% look at this in that group of patients. It may not be enough, but we should look.
So I just want to follow up. So you're saying that you both sound very confident that the initial tests are accurate, that the 18% change is not, random.
No.
Okay.
It's
So apparently, if you look at receptors, the change is only 18%. That's what I would say. If you would look at the
not a lot.
actual biology, it's probably way more.
I'm surprised
But
Pretty low, actually.
But to your point, hormone receptor positive, that's binary, but it's actually, you could be 1% positive or 100% positive. And so there's not enough numbers here to look at, like, to stratify by how hormone receptor positive was the tumor at the beginning. So it's possible that maybe they were like less positive at the beginning, the ones that became negative. So I think,
and we
that's why
know
have to
actually
really-
from your study of the people who do poorly is more heterogeneity in the biomarkers, right? It's bad to have
Mostly, but sometimes it's like one specific clone that gets going.
right. So
Maybe for Rita in iSpy, and nobody can remember why, but estrogen progesterone positivity has been set at 5%. I don't know whether that was done here, but in general in iSpy, it's 5%.
right. We don't
remember
necessarily
why we
agree
did
with
that.
it, but I'm trying to remember. I do. We won't go into that. All right. Any more updates from Sammy?
Somi is going to Johns Hopkins with Molly, and her lesson this year is communication is key. Whether you're talking with patients, advocating for them, pushing forward research timelines, communication is key.
That is true. And she made that happen for our pooled analysis data set. Fantastic. All right, we're going to move on to Dodge, who is fortunately staying with us for one more year. So we're very excited about that. All right, Dodge. I did try, but you'll be here another year. So.
So, hey everyone, I'm Dodge. An important lesson that I learned this year is that you don't always have to say yes to every opportunity that comes your way. Really depends on your capacity and your availability. I learned that this year. And yeah. Cool.
There's always next year, right? So tell us where you're here.
Oh yeah, I'll be staying for second year. So, which is actually really great because what I'll be talking about is what I've been doing in lab, which is kind of different from what everyone else has been doing. I think I'm the only one that works in a wet lab. Unfortunately, I don't have real data. We actually haven't used real samples, but we're very close. I believe this upcoming Monday, actually, we're doing our first samples, not the iSpy ones yet, but I believe they're the DCIS from Rachel and Dr. Campbell's lab. So it's very exciting. With that being said, oh, sorry. Okay. So I'll be talking about analyzing iSpy blood samples using mass cytometry. So I'll be going over the background, the workflow, and then the implications and future directions. So background. So of course, the golden egg to this is the iSpy and the samples that we get from it. Thank you, Maya, for the amazing introduction, but iSpy, it's very efficient and it's very personal towards the patient. And it's very efficient in terms of the several experimental agents that we're able to test out. And of course, it's accompanied with neoadjuvant chemotherapy. Now, mass cytometry, or CyTOF as we call it, it's a scientific method that combines mass spectrometry and flow cytometry. A little bit of a tongue twister, but basically what that means is we're able to quantify over 40 characteristics of an individual cell. Now, the bigger picture is once we get those characteristics, we're able to observe the cell and the sample as like an entire system. And I'll go over that more as I go through my workflow. So an overview of the workflow, we conjugate the antibodies, titrate for the best concentration. We do a viability stain. We soft fix the cells, extracellular and intracellular stain, hard fix the cells, and then we run CyTOF and analyze the data. So steps 1 through 3, conjugating the antibodies. So this is, we're labeling the antibodies with specific metal isotopes. And this is very important so that we can get a signal when we run the machine. Basically, that's how we get our data. It's very important. Next, we'll titrate for the best concentration. What this means is on this graph over here, where it says best range, that's the concentration within that range that we'd want our antibodies in. And it differs for each sample because they're different concentrations. So we have to do a bunch of trial and error to kind of get that range where we get great data with little non-specific binding, which is like background noise, basically. Next, we'll do a viability stain. We'll treat the samples with cisplatin. This basically stains the live cells, which helps us differentiate from dead and live cells. Of course, we want the live cells. Steps 4 through 7, we do a soft fix, and basically a fix that preserves the cell's characteristics at that moment. It's very important. We want the cells to not grow or not differentiate, not change its characteristics, basically. Then we'll do an extracellular stain and then an intracellular stain. What this means is we're basically staining the outside and inside of the cell with the desired antibodies that we want. This is how we get our signals, and we're able to see the markers inside of the cell and on the surface. Next, we'll do a hard fix, 48 hours. This preserves the cell's characteristics again. That's what the fixes are. And we treat it with an intercalator, which further helps distinguish live and dead cells. An intercalator will bind to DNA, basically saying that there's a cell there. And then we'll run CyTOF and analyze the data. So this is what our iSpy antibody panel looks like. What I'm about to show you is a little bit scary and it's all over the place, even for me to this day. But I'll go over it on the next slide, kind of like just some examples. So this is a lot. These are all the antibodies that we're looking for. And again, this is kind of like 2 examples. So on the first column is our channel and then our metal. Basically, what that means is we're telling the CyTOF machine that on channel 141 as the metal PR. And these metal isotopes are rare metal they're rare metals. So it's very specific, basically. And then the protein is CD3, or let's say PDL1. And then the clone is where the protein came from. And then we have our stock concentration that basically what we buy it off from the suppliers. And then we want our titrated concentration. So of course that changes within whatever the stock concentration is and whatever the range for the best titration is, the best signal. So implications and future directions. So this allows us to see the immune system or whatever we're looking at really as an entirety. As we can see, the I-SPY samples, we can, for example, if we had a patient that had, if we have sample from a patient before immunotherapy, during, and then after, we can compare those different settings and see what the immune system looked like. It's really, really cool. And of course, the second point, this can lead to more specific immunotherapies, especially on specific cancer type. And then kind of tying it all together, this allows us to see patients, what the immune system for patients that responded well, didn't respond at all, or maybe patients who had metastatic diseases, right? That is actually the CyTOF machine that we use in lab, that I use in lab. It's called Blue, and right across from it is another one called Charmander. And that being said, that concludes my presentation, and here's my acknowledgements. Thank you.
So I have a question. My first question, so great job. Go back to your list. I want to see if GDF15 is on that list. That,
It is, I don't think so.
can you add anything?
I don't know. I think that's up to Matt.
Okay, we have to ask Matt about that. And I'll explain. We have a neutralizing antibody to that. That would be very cool. So what makes you confident that this is from the blood? What makes you confident that what you're seeing in the blood is a reflection of what's going on in the tumor microenvironment?
That is a great question that I'm not entirely sure I can answer just yet, but hopefully as my time in the lab, I will be able to answer that.
Well, that's what we hope the data will show. I mean, it would be wonderful if we could use it, because then we could get a clue and it'd be hard to get the same kind of data from the cells. But if we combine the multiplex staining with the CyTOF in the blood, that might be, or CyTOF on the tumors and CyTOF in the blood, that might actually give us the answer, or maybe find out what is the most important. So that's good. Other questions that people have? Okay, Dodge, fantastic. We're very excited to get some data in a few weeks. I'll have to ask Matt about the GDF15. Okay. Next up, we are continuing on in our I-SPY quest for information, and Firdaus is going to talk about her work at Berkeley. Come on up.
Hi, everyone. My name is Firdaus. I'll be attending University of Minnesota in the fall for medical school. And something I learned this year is that you can always ask for help. That's what your team is for. A lot of our conversations today regarding I-SPY have focused a lot on patients' quality of life and their experiences on trial. To kind of close out that conversation on I-SPY and about quality of life, I'll be focusing on our work this year to open a satellite site for I-SPY in order to increase access to the trial. So Berkeley Outpatient Center is an urgent care and specialty care facility that opened in collaboration with John Muir Health and UCSF Health in 2018. And within the center, there is a designated UCSF Cancer Center, which offers cancer care services to patients in the East Bay, Greater East Bay, as well as throughout the Central Valley. So we have patients all the way from Reading all the way down to Lodi. And at the site, we have 3 practicing breast specialists, Dr. Marshall, who's an oncologist, and Dr. Abe and Dr. Goodwin, who are the surgeons on site. And a large chunk of these patients who receive their care at the center are breast cancer patients. And among those that are molecularly high risk, there is a lot of interest in the I-SPY trial, specifically in the investigational agents on the trial and the opportunity for de-escalation or going to surgery early. And in previous years, patients interested in I-SPY who were referred from the Berkeley site were required to travel to Mission Bay for that treatment. And that was restricted specifically to Friday mornings, which is when Dr. Marshall's clinic is open here at Mission Bay. Now, if you ever tried to get across the East Bay on a Friday morning, it's definitely a lot of traffic, specifically across the Bay Bridge. And without traffic, it's only about 20 minutes and 11 miles between Berkeley Cancer Center and here. But with traffic, that can very quickly double. And as a majority of our patients are not coming from the immediate Berkeley Oakland area, again, they're coming from the Greater East Bay and all through the Central Valley. So they're experiencing even more traffic down 580 in that little Friday morning. So we're talking hours of traffic sometimes, combined with, a bridge toll every time they enter the city and the restriction of receiving treatment on Friday mornings. Coming to Mission Bay for treatment is often really time intensive, expensive, and inaccessible for many of these patients. It deters a lot of them from enrolling in the I-SPY trial. And this limitation then means that those that enroll in treatment are just only those who can afford that extra time and cost. And that's our primary motivation for opening the I-SPY trial at the Berkeley Outpatient Center, which has been in concept for a while, but more in movement for the last year. To kind of draw out the timeline of events for the site opening over the last year, it began with the Berkeley site staff being trained on I-SPY and added to the delegation log or list of those who can work on I-SPY just last June. And this was followed by a site initiation visit in October, in which the trial sponsors at Quantum met with our site team, including the pharmacy and a new designated research coordinators, to begin establishing the infrastructure needed to access the trial's investigational drugs. And once all the paperwork was approved in December of 2023, the site was officially open to begin enrollment on the trial. And throughout this time, patients referred from Berkeley were still being treated at Mission Bay. So our first goal, once the site was open, was to transition patients currently on treatment at Mission Bay to the Berkeley site. And the first of these patients was transferred in January of this year. And once those patient transfers occurred and the site staff better understood the workings of the trial for both the chemotherapy and endocrine therapy or EOP arms of the trial, we enrolled our first new patient who would be exclusively treated at BOPC, specifically on the endocrine therapy or EOP arm in April. And this was followed by our first Berkeley exclusive patient on chemo in May. And just 2 weeks ago, our first patient to start on Block A investigational treatment at Berkeley. Now, this rollout was not without its challenges, which we'll focus on 3 mainly. And the biggest challenge that BOPC faces is that there is, at the time, there was a lack of a usable breast MRI on site. And frequent imaging is a huge portion of this trial and a lot of the decisions made. The second challenge we faced was that the pharmacy staff that's on site is not exclusive to research patients. So they are supporting standard of care patients at the same time as these research patients. And they don't have the exclusive time to dedicate to prepping these investigational drugs. And lastly, the coordinator on sites here at Mission Bay typically drop off all blood samples for the study at BIOS, which is the blood processing for us. There is no comparable facility at BOPC. So to operationalize the trial at this site, we had to find solutions to those challenges. The patients will for now continue to receive their MRIs here at Mission Bay in those designated research slots. And to plan around the pharmacy's busy workload, the providers and CRCs currently plan for some extra time in between randomization, which is when patients are assigned to a treatment, and their actual treatment start. So the pharmacy has more time to prep those drugs. And Lastly, to make sure all blood samples on site were processed within 2 hours of being drawn, all CRCs are trained to process the blood themselves and freeze it in order to ship it to iSpy Lab. And so opening the site has led to some wins for these patients. First of all, we were able to increase enrollment from previous years. So in 2022, there was only 8 patients from Berkeley that were able to enroll on the trial. But in 2023, once providers began presenting the options to patients that they may inevitably receive treatment at Berkeley on trial, 12 patients were enrolled. And this year, we now have we currently have 6 new patients in the first 6 months of the year, so we're on track to have around the same numbers. Secondly, I was able to poll 5 of the patients who received treatment both at Mission Bay and at Berkeley, specifically about their kind of travel time and expenses. And these patients reported saving an average time of 1 hour of travel time and $100 per treatment visit on iSpy by moving over to Berkeley as opposed to Mission Bay. And these 2 wins kind of show us trending in the right direction of allowing patients to have a better experience on the iSpy trial by opening this new satellite sites. But these successes were not obviously without some problems. The biggest problem that remains slightly unsolved for the Berkeley site is that labs at the Berkeley site are processed in 1 full business day as opposed to 30 to 40 minutes here at Mission Bay. So that often means that patients have to make 2 visits to the site for a single cycle of treatment. The first day they will come in, see the provider and get their labs. And the second day they'll come in for their infusion once those labs result. And this presents a little bit of a problem for patients who are coming from, again, the Central Valley or farther out. We've currently introduced for patients, those patients that if they need their they would get their standard of care labs done closer to home a day before using a facility like Quest or LabCorp. And then they'll come in for their infusion and their provider appointment that next day. But again, coming in twice is more difficult than just coming in once, as here at Mission Bay. And enrollment at the site is also limited to the practice of a single breast oncologist with a very busy schedule. So planning, treatment starts just a couple of weeks out is often very difficult to line up all the appointments. Lastly, for the past 6 months, there's also no designated CRC on site at all times. We had our CRC would come in for pertinent patient visits and for blood draws, but would otherwise work remotely. And being limited to just this 1 CRC, enrollment is also limited to 2 screening patients at a time and a total of 8 patients total on the trial. The last thing I wasn't able to include on the side is that there's a couple procedures that patients still have to receive in Mission Bay. One is those MRIs, as well as sometimes those 12-week biopsies and those eye exams they receive as part of treatment. So the key takeaways from this experience, opening a satellite site for this is showing that opening satellite sites for clinical trials can increase access and better patients' experiences, and should be part of our goals of increasing health equity overall, increasing access to these opportunities like de-escalation. And it also proved that as long as there's careful planning, trials don't need to be exclusive to large cancer centers with a lot of infrastructures. It just takes a little bit more time to operationalize these opportunities for patients, but that's worth it to increase their experience overall. Lastly, these lessons can be applied to opening future trials at future other sites, including Highland Hospital, which is hoping to open iSpy soon as well. As for next steps for the site, we are hoping to become more independent of Mission Bay, obviously. So we'd like to build some couple workflows to make sure that patients can get those extra biopsies and those extra eye treatments on site in the radiology and ophthalmology departments that exist at Berkeley Outpatient Center. There is also now a breast MRI on site for Berkeley, but it's not yet open to research patients. So hopefully that's a goal of ours so that patients can come into just Berkeley for those MRIs as well. And as of this week, there's a new on-site CRC at all times. So hopefully they will be able to operationalize those goals over the next couple of years. And thank you.
So great job. And I would say that, is maybe part of the lesson that even even once all of the procedures are able to be done at the Berkeley Outpatient Center, do you think it's better for them to be completely independent or stay as a satellite of as part of UCSF?
I do think it would be better to stay as a satellite to have like access to the greater knowledge base that would exist here at the main site. But by allowing a lot of those procedures to be done at Berkeley, it opens up appointment times here at Mission Bay so that there's not less burden on Mission Bay to support another site.
Yeah. And there are also, it leads to innovative ways of distributing trial services. I know Neil Pasrica is working on the eye exams by iPhone. That you can do it and he can see it right from there. So that's, if you required everyone to come in, no one would even try and innovate. So that's a good thing. Have you guys looked at thinking about sending a courier over with the labs? For the labs, so you get, instead of of course, then they have to go across the bay.
I think a lot of the labs do come here by courier, which is why they take a day. I've noticed there's some samples they process on site, but there's only ever one or two people in their lab, which is why a lot of the samples are sent here to be processed, which is why it takes a full business day.
I see. Well, but then again, there really isn't anything that can't be done at a Quest lab somewhere nearby, right? Laura.
So in an earlier presentation, we heard that I think for the patients, to sort of think about whether there should be sort of an experienced patient group that you can call or however you contact, and maybe that's particularly important for a group like this, because sort of the density of people at that site that know everything about iSpy is much less. Mm-hmm. Is there something that if they have a question already have maybe even a physician they can call another one, or otherwise
Jane is working on that for actually all sites. We now have close to 20 satellite sites on the trial. So I think it's really important. And that's sort of one of the goals that she stated at our last meeting. Yeah. At the, whatever that meeting is on Mondays, exec ops operations call. Yeah. So, but I think that again, so my last question to you is, so one of the lessons is that it's been 2.5 years that we've been working on opening, moving the services, transitioning the services to Berkeley, and they have more resources than Highland. So maybe even though we've been working in similar ways for Highland, they have even less infrastructure, but the idea of working as a satellite that's working to more independence is probably the right message for that site, correct? And maybe that's what do you think?
Well, from what I've known from attending the Highland meetings, they're not a satellite, but they're attempting to open as independent. So that might be a little bit harder because they're not able to access like local facilities or like other facilities in the same way. Okay.
Given your experience of how hard it's been at BOPC, would you recommend that they rethink their position?
I'd say no, because the patients are just so excited about the opportunity. So being able to inevitably get there would be a good goal.
I mean, how to start? How to start?
I'm not sure.
So I think this experience really does help us to think about that. And the other thing is, if you don't have an experienced investigational pharmacy, Highland is literally a quarter mile from Berkeley Outpatient Center. So I'm working to try and go back to this model where we start with a hybrid and they work towards independence. And that's be a better way to get them on.
One other idea was, and maybe this is based on my experience, as you may know, I'm a biologist, right? And all of a sudden I was propelled in a clinic. And so one of the things that actually made me realize what it was needed to do, this was at the time when the BRCA1 testing just started. And I was invited in a patient communication group among patients who turned out to be BRCA carriers, who were going to treatment and were talking among themselves. And so they had asked me to explain whatever was going on with BRCA testing. And so do you actually have such things for any of the I-SPY patients, that you provide like an opportunity to talk to your fellow patients like once a month in Tuesday afternoons?
That's what we're setting up. That's what Jane is setting up with Tracy. Yeah. So this idea there, as I said, there isn't a support group now, but it's something that we're trying to have set up. That's sort of one of their goals. Okay. All right. Thank you. Awesome. Okay, next we have Astrid, our resident dance instructor, just saying that July is going to be the month we start our at least monthly salsa classes at Mission Hall in the lobby there. Okay, Astrid, we're looking forward to your talk.
Hi, everyone. Who would have thought doctors also know how to dance after this next year? So, as you heard about the process of starting a new clinical trial, I'm going to talk about the process of starting a new project that's going to look at invasive lobular carcinoma in the next decade. So, what is invasive lobular carcinoma? Also known as... Okay, I'm giving two presentations. So, for this presentation, one of the biggest things that I've learned is that there's always ways to go about barriers, and you'll see why. Given that ILC is the second most common histologic subtype of breast cancer and comprises about 10 to 15% of all breast cancers, it is estimated that 40,000 women will be diagnosed with ILC this year. And on a cellular level, ILC is characterized by the loss of an E-cadherin protein that leads to a diffuse growth pattern. And it is this diffuse growth pattern that contributes to its barriers and suboptimal outcomes we see today. The diagnostic barriers include a lower sensitivity of screening mammography, which leads to patients presenting at higher stages. When it comes to treatment, there's a lack of tailored therapy, and higher positive margin rates means that patients will have to go back into the operating room for re-excision. And when it comes to surveillance, patients with ILC have a higher propensity for late recurrences, and we currently do not have ILC-specific guidelines. And so with all of this in mind, the UCSF Lobular Breast Cancer Research Program was established in 2016 under the direction of Dr. Rita Mukhtar. And this past year, I have had the opportunity to work as its research coordinator, coordinating its many projects. And one of those projects is a retrospective database containing information on over 1,000 patients that were treated at UCSF for ILC. However, the limitation with this retrospective database, even though we are able to advance a lot of analyses and a lot of research, one of its limitations is that we don't have enough follow-up data once patients leave UCSF. And once patients leave UCSF, given that this subtype has a high propensity for late recurrences, it becomes imperative to be able to follow up with patients and see how they're doing. And so we decided to prospectively track the barriers to diagnosis, treatment, and recurrence detection through the ILC prospective registry. And so I'm going to walk you through the process of how we started to build this prospective registry that's going to withstand this test of time. And so first we had to identify patients, and we identified patients by creating a query in the electronic medical record that would identify patients with ILC. And in addition to that, we also screened the breast care center's schedule for any providers seeing patients with ILC. When it came to recruiting patients, through the participant recruitment program, we outreached to over 1,300 eligible participants, and 294 of them expressed interest in the registry. 63 have been contacted and 50 were enrolled. With the clinic screening and referrals, we contacted 8 patients and enrolled 8. So next we had to optimize our database to be able to capture all of the data that we expect to see in the next 10 years. And so we categorized patients into 4 groups, whether they had de novo metastatic ILC, had a distant recurrence, had a local recurrence, or no recurrences. And then every year we would ask everyone for updates on their treatments and screening. And we would also collect recurrence information on anyone with a local or distant recurrence. And finally, we would also collect sites of metastases for those with de novo metastatic ILC and anyone who ended up having a distant recurrence. And so the next challenge was figuring out the most optimal database management system. And so we originally thought of using REDCap as a tool to manage all of our data. However, it was very expensive and it was approximately $15,000 to $25,000 to be able to have consultants build certain functionality for our database, even though REDCap could offer easier data entry. However, we ended up going with Excel because it was cost effective, it was easier to build in, and even though data entry might prove to be difficult 10 years down the line. So once we created this schema and once we established all of the data points that we wanted to capture, we conducted 58 interviews and each interview ranged between 30 minutes to an hour. And in these interviews, we really got to listen to patient perspectives on their journey to diagnosis and how their treatments are going. And we also provided patients with resources on ILC. And so even though our prospective registry is still in its early stages, I want to walk you through some of the descriptive statistics of our cohort so far. So we enrolled 58 patients and the mean age was 58 years. 58% of our patients were stage 2 and 80% of our patients presented as ER positive, PR positive, HER2 negative. And 75% of the patients had a grade 2 ILC tumor. In terms of systemic therapy, 54 out of the 58 participants received adjuvant endocrine therapy, and 14 of them received neoadjuvant endocrine therapy. 12 participants received adjuvant chemotherapy, and 6 of them received neoadjuvant chemotherapy. And this is a distribution of the local therapy that was received. So 39% of the participants received lumpectomy and radiation, 27% of them received a mastectomy, 24% of them received mastectomy and radiation, and only 10% received lumpectomy alone. 18 out of the 58 participants elected for a bilateral mastectomy, while 42 of the participants had a breast conserving surgery or a unilateral mastectomy. And so we really wanted to look at how the initial ILC was detected and compare that to the type of screening the patients were undergoing. So for the patients that were undergoing no screening, all of their ILC was detected because of a physical finding. For the participants that were screening with a mammogram, 55.6% of those participants had their ILC detected by the mammogram, while 41.7% of them, even though they were undergoing mammography screening, they had a physical finding, and that's what detected their ILC. For the participants that underwent breast MRI screening, 66.7% of them had their ILC detected by the breast MRI, while 33.3% of them had their ILC detected by a physical finding. And it's important to note that all of the patients that were screening with a breast MRI were also screening with a mammogram. For the participants that were screening with a breast ultrasound, 46.2% of those participants had their ILC detected by a mammogram, 30.8% of them had their ILC detected by a physical finding, and only 7.7% of them had their ILC tumor detected by the breast ultrasound screening method. And so we really wanted to look at the method of ILC detection and look at tumor factors. And so we found no difference in overall stage, grade, or receptor subtype by the method by which the ILC was found. But we did see differences in the mean tumor size by method of detection. And so as you can see here, if you had a physical finding and that's how your ILC was detected, you had a larger mean tumor size, and this analysis was statistically significant. And so the key takeaways are that ILC is a unique tumor type that needs specific research studies, and the risk of late recurrences means that long-term follow-up is desperately needed. And our prospective registry is still in its beginning stages, but we do hope to provide insights into associations between treatment type and long-term outcomes. And by prospectively following patients, we hope to better tailor our therapy for this subtype. And I want to thank my mentor, Dr. Mukhtar, and all of the lobular research team and the BCC internship.
Okay, great job. Do you think it would be easier to do this prospective registry if we had a standard where we prospectively followed all of our patients?
I mean, I think you would need IRB approval for that. and their consent. But I do think that this prospective registry would probably be a lot easier if the patients, yeah, if that was the standard. It would make my job easier too.
Yeah. Well, so let me ask you a question. You're about to be a physician so soon. You're going to be going on that journey. So do you think it's the job of a physician to track their patients and find out what happens to them after they do interventions for cancer or various things that we do?
I do think it is important because how do you know if what you're doing is accurately helping the patients in the long run?
Excellent point. So why should we be going to the IRB to ask for permission to do our job? Do you have a good answer for that?
Maybe people don't want to get sued.
Well, is our goal. I have a new plan to accelerate our ability to do that using the interns as part of it. Jeff, I will be speaking with you about this tonight.
Yeah, I just want to make the observation that to Laura's point, Laura's been talking about the routine monitoring of patient outcomes for a long time. And, you know, this registry is so great. There were 1,300 people eligible and ultimately 58 put on it. So that's a tough ratio. I want to contrast that. You know, sometimes we get stuck in like healthcare is so hard and healthcare is different. And, you know, let's just take the sports industry for a second. Sports industry is $160 billion worldwide. I think about half of that in the US. And they track every outcome of every play at every level in baseball leagues down to like way down into the minor leagues.
Fantasy and in the fantasy games.
Yeah, no. So, you know, the fact that, I mean, it's just the healthcare industry is $800 billion in the US. So there's plenty of money in sports to track the outcome of every, you know, play at every level down to the lower minor leagues. It's really just a failure of imagination and will. And maybe, you know, maybe we need something really different. Laura, you're going to like this idea. How about if we set up predictive markets, also known as gambling, for the outcomes of patients? You know, then we would get real money into the system. And also we could get rid of all this classical statistics and we get some Bayesian statistics, because then you'd really have to be able to predict outcomes with some.
Right. I love the idea of following it in some ways. Can we get rid of the gambling though? Can we find me something slightly different? But
as John Doerr says, no conflict, no interest.
Anyway, well, so yeah, so I mean, I think it's fantastic. This just goes to show how important it is. But this needs to be the routine of everything we do. This has been my dream since I started the Breast Care Center. And my goal is to make sure it's done before 2028, which is what one of our former interns said we were going to be rolling out one source. So anyway, we just have to beat 2028. So 2024 seems to be a good year, I think. Yeah. I think
it will.
Great job. Hey, we have to send out unfortunately, Astrid will be here next year. So we're so excited about that because she's going to be sending out the dance schedule shortly. Okay. Okay. Kelsey, we have 3 more before lunch. There are 3 people standing between you and lunch. Kelsey, don't forget to start with most important lesson to our return. 2 years. Fantastic. We've had so lucky to have you for 2 years. So most important lesson for this year, and maybe how it was different from last year. I don't know. I can't remember what you were anyway, and where we're going next year.
Hi everyone, I'm Kelsey. And thank you. Ashton's a bit taller. And one of my most important lessons that I learned this year was due to Dr. Esserman's Idea to Impact course that I took. And it was a leadership course that really focused on how healthcare, we can build leadership skills and talk about like influence and power. And so something I learned there was just to get out of my own way and out of my own head and step into more advocacy and action. So that's how that differed from last year. Okay. And so related to Astrid's talk earlier, in her wonderful presentation, registries are obviously very difficult to start, but super important to tracking patient outcomes. And so today I'm going to talk about the metastatic breast cancer registry and brain metastases. So brain metastases, also known as brain mets or secondary brain tumors, are cancer cells that spread from another part of the body to the brain. Brain mets are diagnosed based on convincing radiographic findings on MRI brain, on the MRI brain. And roughly 30% of patients with metastatic breast cancer develop brain mets during the course of their disease. Past literature has shown that predicting individual patient survival after a diagnosis of breast cancer has proven to be difficult, especially in identifying potential long-term survivors. So as brain mets are a devastating complication of metastatic breast cancer and the most common type of brain tumor, it is critical to better understand the risk factors, natural history, and treatment outcomes, especially for patients in a modern cohort, which we have here at UCSF. And so today our objective is to look at how people are doing with treatment in a more modern time, comparing 1997 to 2014 versus 2015 to 2024 cohorts. So the design of this study was a single center retrospective cohort study, and we identified patients with MBC and brain mets through institutional cancer registries who received care from 1997 to 2024. And we used the electronic medical record as well. We then abstracted key clinical and demographic characteristics, treatment history, and survival data. So going into more of the patient demographics, in our registry, we identified 484 patients with MBC and brain mets, and most patients were female with a median age of 47 years at time of MBC diagnosis, and 86% of our patients identified as non-Hispanic. And then here's like a racial breakdown. Obviously, you can see that there is a majority of white patients, followed by Asian and going in and zooming into the tumor characteristics and biology at MBC diagnosis, patients had the following breast cancer subtypes, as you can see with this little chart here. So HR positive and HER2 negative was roughly 38%, 39%, and then HER2 positive was 37%. Here it's split up, but I grouped them together as HER2 positive. And then triple negative breast cancer is 24%. So this kind of contrasts to primary cancers, where normally the breakdown is 75% or 70% HR positive, HER2 negative, and then 15% for both HER2 positive and triple negative breast cancer. Oh, sorry. And then also most patients had ductal histology, and 17% of our patients had de novo metastatic disease, which is defined as when cancer has already spread to other parts of the body by the time of initial diagnosis. So now here we're going to look at median time from the diagnosis of MBC to brain mets, which was 8.1-ish months and varied by MBC subtype, as we can see, with longer median time from MBC to first brain met with HR positive, HER2 negative, around 16.2 months. And this differed from HER2 positive, which is around 8.1 months, or triple negative breast cancer, which was around 2.1 months. So again, this is looking at when you're diagnosed with metastatic breast cancer to then brain mets. So another complication of MBC is also called leptomeningeal carcinomatosis, or LMD. And this is defined as cancer cell infiltration into the leptomeninges. And this is from a primary tumor. So LMD can be diagnosed based on positive cerebrospinal fluid, or CSF, and also convincing radiographic findings on MRI. And LMD was once thought to be a rare complication of MBC. However, newer studies show that LMD comprises up to 11 to 20% of the burden of central nervous system disease. And in our cohort, we identified 90 patients, or 18.6%, had developed LMD in addition to brain mets. And the median time from first brain met to LMD was 6.6 months. And as you can see, this also varies by subtype. And then with it being a shorter development of LMD for HER2 positive and triple negative patients. And then also important to note, but for triple negative patients, there's a shorter time frame from diagnosis of LMD to death. So after the diagnosis of brain mets, most patients received central nervous system directed therapy. Here we can see that our patients received a combination of surgical resection for brain mets, whole brain radiation therapy, and stereotactic radiation therapy or gamma knife radiation therapy. And then moving on to survival data, luckily Dr. Esserman gave a really great breakdown of what a Kaplan-Meier curve is, but here I have just selected a couple to talk about. So as we can see, the median overall survival for our cohort was 21.7 months. But breaking it down into subtype, patients with HER2 positive survived longer after a brain mets diagnosis than patients with HR positive, HER2 negative disease, or triple negative breast cancer. And then interestingly, median overall survival did not differ based on ductal versus lobular histology. And it also did not differ based on date of brain mets diagnosis in the cohorts of 1997 to 2014 versus 2015 to 2024. And what I have kind of hypothesized is that this could be due to the fact that the number of brain mets diagnosis has actually risen recently because we have gotten better at detecting them, as well as better treatments for primary cancers. And so because of this, more people live longer with primary cancer and the disease might have more time to spread to the brain. And then going back to LMD, patients with brain mets and no leptomeningeal disease survived longer than patients with brain mets and concurrent leptomeningeal disease. And so this is a univariable and multivariable analysis, but essentially what it's showing us is that patients with HER2 disease, stereotactic radiation therapy, and brain met surgical resection were associated with a longer survival time than those with different treatment options. So kind of going into our takeaways and next steps. So patients with breast cancer, brain mets exhibited a median overall survival of 21.7 months after brain mets diagnosis. And as we discussed, patients with HER2 positive disease and those who underwent a brain mets resection and or gamma knife therapy radiation had the best prognosis. And there is also, again, this is different to what we had expected, but there's no difference in survival between patients diagnosed between 1997 to 2014 and 2015 to 2024. And so that's something that we want to look into more and kind of suss out where we might find those differences. And also, and going into more next steps, the treatment of breast cancer, brain mets remains an area of unmet clinical need that we need to kind of explore more. And we're hoping to annotate those differences by looking into different systemic therapies that were used to treat these patients. So looking at the chemotherapy, the lines of therapy, and different novel agents. So that concludes my presentation, and thank you to everyone and my wonderful mentors.
Thanks for a great job on presenting that. So one thing I noticed was on one of your last slides is that that whole brain radiation wasn't really associated with much improvement. And I'm actually surprised to see that the survival is so long, 21 months. But the one thing we know about whole brain radiation is that it is probably a reasonable palliative procedure, but if you are going to live for more than 6 months, it really makes you lose your cognitive function. So I'm just wondering, is the use of whole brain radiation, I'm surprised to see whole brain radiation being used at all. And I suspect it continues to be used at many places around the country, maybe not so much at academic medical centers, but has that stopped at UCSF?
Yeah, so I think, like you mentioned, it is used in a more palliative setting for some of these patients, but I think it's also because we had a cohort starting in 1997. That's where the majority of the whole brain radiation therapy patients are coming from. And now it's a lot more popular to have the gamma knife radiation therapy.
Yeah. And I think that a lot of people probably give whole brain radiation because they don't realize that the median follow-up time is 21 months. So that alone may be the most important thing for you guys to publish. And just while you're here, maybe I think one of the projects that you've been involved with that has made a huge difference in our clinic is the Breast Cancer Cafe. Maybe you can maybe just make a comment about what you think. What do you think has been the most important contribution you think to of having that program be up and running?
Yeah, I'm gonna shout out Shelly because she's really like the founder of the cafe, and she's been incredible. And I've learned so much from her just about true patient advocacy and care. And I think what I've learned from that is definitely how important it is just to center patients' concerns and how just even talking through their different anxieties or their different questions can really help them to feel more at peace with their treatment decisions and also with their diagnosis. And so I think that that's something that's really powerful that I didn't really know before entering this program. So I'm really grateful to her and to this program.
Great. Thank you. I also want to note, I like seeing the pictures of all the interns. It's one of the things that's most gratifying to me about this program is the long-lasting friendships that people develop over the many years. I'm still get, I just was in New York the other day and randomly got stopped by Nick Dreyer and Fiona Wilson, who just came up to me and said, "Oh, Dr. Esserman." I was walking down the street, 2 interns from the program who got married. Anyway, so very exciting. One of several, yes. Requirement if that happens is you have to name your children after Jeff or me. Okay, so next up is also our return. Rachel Woody has been here with us for 2 years. Thank goodness, since it's been a very eventful 2 years, I would say. So Rachel's going to talk to us, moving things even farther back to DCIS or high-risk DCIS. Rachel.
Okay, thank you, Dr. Esserman. So I have been, as you said, at the Breast Care Center for going on 2 years now. And I think the thing that I've learned most from observing Dr. Esserman and her clinical team move mountains on behalf of patients every day, and I see Susie there and I see Kristen, is truly that no matter how busy our schedules get inside and outside of healthcare, and no matter how important our personal agendas may seem, the first and foremost priority at the end of the day will always be to take care of one another and to take care of our patients. So I will be talking about, next year I will be joining several of the other interns at UCSF for medical school. So I'm very excited to stay and hopefully hold on to the connections that I've developed here, which really mean the most to me. I've adored everyone that I've worked with during my time.
Our next Sparking Innovation.
Yes, I would love to join Sparking Innovations as well. Okay, so Kelsey gave a presentation on brain mets that was really informative, and what better way to prevent brain mets and invasive cancer than to address in situ cancers right away and prevent them from becoming invasive. So I will be talking about specifically women with a diagnosis of ductal carcinoma in situ, and the efforts that Dr. Esserman has been making here, along with Dr. Campbell and the rest of the research team, to develop an alternative treatment for these women who are typically sent to surgery for a partial or full mastectomy. And so specifically on this trial, we are targeting women who have features associated with features of their DCIS that are associated with a higher risk of becoming invasive. And these are things like a hormone receptor negative lesion, HER2 positive, a large palpable mass greater than 5 centimeters in size, a high grade DCIS, and a time of diagnosis prior to 45 years of age. The reason this is so important to separate out different types of DCIS is because not all women with DCIS have the same risk of recurrence. So if you have a lower risk of DCIS, you could go on to a trial like active surveillance and receive more frequent imaging. But if you have a higher risk, it seems like some intervention is needed. But we are just questioning here whether it has to be surgery. So the trial that is currently underway entails patients coming on with an initial pre-treatment biopsy and MRI, and then undergoing a series of anywhere from 2 to 4 injections, which are administered directly into the lesion of the breast, and which contain in our past cohort of 10 patients, contained a combination of a PD-1 inhibitor called pembrolizumab and an mRNA agent. And then finally, after receiving these injections spaced 3 weeks apart, patients go on to receive a post-treatment MRI and then either a biopsy or a surgery as needed. And then we collect the tissue samples from before and after treatment, and we run various assays on them. And so one of the assays that we run is called multiplex immunofluorescence imaging, and it produces beautiful pictures like this. In the yellow, you could see an example of a DCIS lesion, and surrounding it in pink and green, respectively, are the B cells and T cells. So that's the immune system at work. And so the idea behind using pembrolizumab, a PD-1 inhibitor, and mRNA, is to change the images that you see on the right side of the screen, A and C, to resemble more closely the images on the left side of the screen, where you have a lot more dense immune infiltrate, and also the immune infiltrate has converged onto the tumor and is now interacting with it and hopefully reducing the size or even eliminating it completely. So this is a phase 1 study, but we are starting to address 3 main questions. First of all, can this therapy produce clinically significant responses? Additionally, is it tolerable and safe for patients? And finally, are there features of the immune microenvironment around patients' DCIS that is associated with a beneficial response? And so to answer the first question, on our pilot study of 10 patients, we've seen that yes, in fact, we can use an intratumoral injection prior to surgery to get rid of DCIS in some cases, and in others significantly reduce the size so that they could have a smaller excision. And here you can see a plot of the reduction in functional tumor volume as shown on MRI. So you can see that for 6 of the participants below the horizontal line, we could see on MRI that the volume was significantly reduced, and the red asterisks indicate patients who had a complete pathologic response, which is when we looked at the tissue and what was happening on a cellular level. And then this is an image of what a complete response can look like. So on the right side of the screen in the red circled region, you can see an enhanced white area where the DCIS was, and then just 2 injections and 6 weeks later, you can see on the left side of the screen the resolution of the mass. Okay, so now addressing tolerability, which is really the crux of a phase 1 trial. we have here plots that show the duration along the x-axis that patients experienced each symptom and side effect of the injection. And then the colors represent the type of side effect that they were experiencing. So in light blue, you have the breast symptoms that they experienced. So things like pain, swelling, and itching and peeling of the skin. In gold, you can see the axillary symptoms. So patients would experience swelling and discomfort in the lymph nodes. And then in green, we have fever, blue, dark blue, flu-like symptoms, and then in orange, miscellaneous things. The only one of note I would say is the one patient that we had experience hives, which eventually resolved. So ultimately, the takeaway from this is that we did not have any long-lasting serious side effects. And so this is a safe treatment for patients. Okay, and the final question that we are asking is whether there are components of the immune microenvironment of DCIS that are associated with a response to immunotherapy. And the reason this is so important is because wouldn't it be great if we could just take a snapshot of a patient's immune profile and make a prediction as to whether or not this immunotherapy is a beneficial option for them? So what we have found is from looking at those immune multiplex images I showed earlier is that there are in fact distinct differences between the immune profile of patients who will respond to the therapy and those who typically do not. And so you can see here on the box plot, PR and CR represent partial and complete responders, and they have significantly higher amounts of tumor infiltrating lymphocytes up front. We also found higher percentages of T regulatory cells and of PD-L1 positive cells in the group of patients that did respond. So this is an interesting way to start predicting who will benefit from this therapy. Okay, and most recently we have run a cohort of 11 patients who received the mRNA-2752 on its own without that checkpoint inhibitor pembrolizumab. In this cohort, we halved the dose of mRNA to try to reduce toxicity, and we're still working on analyzing our data. We have seen at least one complete response, so we know that this version of the therapy can work, but overall it may not be as consistent or robust in terms of the responses it's producing as the combination therapy. And again, we haven't seen any systemic long-term serious side effects. Okay, so the next steps. We know this is something that can work. So how can we understand the biology to better target DCIS? We're running a bunch of different assays right now. So the spatial transcriptomics assay, we're looking at the peripheral blood, which Dodge talked about earlier. And we're also collecting stool samples to look at the microbiome. And then hopefully we can, moving forward, reduce the toxicity by finding the right formulation that works, get this into trials and make it the new standard of care to save women the unnecessary hardship of recovering from a partial or full mastectomy when they could maybe just have this less invasive intratumoral injection instead. Okay, and then finally, we concluded that manipulating the immune microenvironment around DCIS can be an effective way to reduce the progression of disease. Thank you so much.
So this has been a very taxing and intensive trial. Obviously, patients who are coming in want to have an alternative to mastectomy, which is what most patients with these big lesions would have. By the side effects, do you feel like most patients feel that especially if the disease went away, that the side effects they've experienced were worth it, or not, they wouldn't do it, even if it worked?
Yes, so across the board, patients are extremely excited about the opportunity to participate in the trial. They always find us rather than the other way around. And to be honest, even when the treatment doesn't work out, our participants have been extremely consistent in saying that they feel that it was a meaningful thing that they did, that they were grateful that this is under development and to have a chance to contribute to that development of a less invasive option.
So it's always hard when you're doing something new, to know whether it's worth the effort to keep going, especially with the combined therapy. Would you say overall that we have proof that it can work, and it's worth continuing, or is it just too variable, too hard? What do you think?
Yes, so absolutely. This is something that can have a very exciting response for patients. And moving forward, we have talked about ways that we can add in another PD-1 inhibitor, maybe cemiplimab, to continue this line of development. So it's very exciting.
Yeah, I mean, having listen, nothing ever works out the first time. My mentor was Ron Levy, who's one of the pioneers in antibody directed therapies for lymphoma, and his famous line is, first patient we treated, who actually was treated when I was in his lab, his name was Phil Carr. He became very, very famous, spoke all over the world, and Ron said, our first patient was a complete success. We spent the next 10 years trying to figure out what went right. So that is job security for your research. And I think that's how we feel in iSpy. We have proof positive that we can get people to a complete response. We have proof that we can actually turn these things around and make them go away. Now we just have to figure out how to fine tune it. And your expectations have to be moderate, in that, like, it's just, much as you'd love to have like every scan show you that it's working, it's just not, it's going to take a while, but we know we can get there, and that's what's so exciting. Yeah, so that's the whole, but that's the reason to do research, right? And actually, one other reason that I think it's so important to do research, I often get criticized for dismissing people with DCIS, and Steve Nayrod in particular is a Canadian epidemiologist and physician, saying that he thinks that there are patients who actually show up with metastatic disease. In fact, one of my patients with DCIS, next presentation was metastatic disease, and I went to her memorial recently. It's very hard, but people with this kind of DCIS are the ones that can do that. And it's not very common, maybe 5% of the time, 3 to 5% of the time. It's not enough to give them chemotherapy or anything that's really toxic, but it's there. It's a real problem. And so doing something like this, that is not just dealing with the DCIS in a surgical way, but also thinking about trying to prime the body for an immune response, might eliminate that risk. Of course, it might not, but that's another really important reason to do it. And one of the comments people say, well, you've got a treatment. One of my first, that's when people whine or complain, I don't know, whine, but say that they're unhappy that their grants got turned down. I'll tell you, my first grant, which Ron Levy was part of, for doing a HER2 vaccine for DCIS, the reviewer said, there's a treatment for that. You can just do a mastectomy. Why are we doing research on this? 1996. Okay, so there you go. They turned out to be wrong, but that's the important thing, is you got to have faith and you got to outlast people, right? Thank you. All right, standing between you and lunch is our video from Natalie Kim. She's doing it live, or it's a video, right? Video, because she is on her way, I think, to Norway with her family. Don't try that, any of you interns this year. We need you here in person. But Kristen and Susie, we want to thank you for being part of the DCIS vaccine. We hope that you see a big hand of applause. By the way, this trial wouldn't happen without. I know, Kristen, you sometimes get stressed out by these people coming from all over the country, and it is really stressful. It is stressful for me too. It's not that I don't think so, but I hope this gave you a sense of what we're doing, why we're doing it, and that we really believe that anyway, that within the next few years, this will be the new standard of care, but it's going to take a lot of work. And there's unfortunately going to be a lot more of these patients. So just gird yourself. It's okay, but we're going to have more help. Thanks to Susie, who's making it all possible to see more of these patients. Okay, thanks. All right, Francesca, are you going to play? Oh, I just go next. Oh, the next one. Okay. Okay, good job.
Hello and good afternoon. My name is Natalie, and we just had a wonderful presentation from Rachel about decreasing the risk for high-risk DCIS patients. But what if we could detect high-risk DCIS and even invasive breast cancer before they get to that stage? My project is on assessing liquid biopsies for early and accurate detection of breast cancer. This is a collaboration between the Athena Breast Health Network and Exi Bio. My mentor for this project is Dr. Laura Van Beer. Liquid biopsies, are they the future for breast cancer diagnoses? On the left, you can see a blood draw versus on the right is a traditional tissue biopsy, which is done with a fairly large needle. Traditional biopsies assess whether there are cancer cells present by pathological assessment. So for example, looking at the cells under a microscope. Liquid biopsies, on the other hand, can assess whether there are circulating tumor derivatives associated with cancer in circulation. For example, tumor cells, tumor DNA, or tumor RNA. The central question of this project is, can circulating RNA predict who will develop breast cancer? Again, this is a collaboration between the Athena Breast Health Network and Exi Bio, which is an emerging biotechnology company. The Athena Breast Health Network has a longitudinal cohort of healthy women who receive screening mammograms, and we will be specifically focusing on the participants who had their screening mammograms done at UCSF and who have a banked blood biospecimen sample. We also have all of the outcome data for all of our patients. The goal is to validate the Exi Bio developed oncRNA blood test to predict cancer occurrence within 2 years before the actual diagnosis. Our secondary questions are, can the test accurately discriminate between benign lesions, DCIS, or invasive breast cancer? Here's a little bit of background on how the Athena Breast Health Network works. So patients have their mammograms scheduled at UCSF, and this triggers the Athena Health Questionnaire, which is sent to the patients by email to be completed before their appointment. This is then run through our Salesforce platform, and this uses the information to generate a risk assessment to identify those who are at elevated risk based on personal health information as well as mammogram density. The information can also be used for research if a participant consents to release their data for research, and a portion of these women also agreed to donate a blood biospecimen sample. Exi Bio has determined a test for early and accurate cancer detection from just a blood sample using oncRNA and artificial intelligence. We've learned over the past decades that cancer is a disease of disordered gene expression, including tumor suppressor genes and oncogenes where protein function gets altered. More recent research into the field has started to appreciate the role of cancer-specific orphan non-coding RNAs, also termed oncRNAs. These oncRNAs can reprogram the cancer genome by changing the gene activity profile. For example, they can impair the function of protein encoding RNAs by directly binding to and shielding them. And these oncRNAs are not transcribed. Here you can see an overview of the abundance of oncRNAs in breast cancer, which is the yellow bar at the bottom. And this is measured here across thousands of short RNAs. This is mostly absent in normal samples and is also now validated in recent cohorts. OncRNAs provide a very abundant signal because they are actively secreted from living cancer cells. OncRNAs in aggregate can create unique patterns by cancer type and even subtype. Just one oncRNA on its own does not give a whole lot of information, but XiBio has harnessed the use of artificial intelligence to recognize unique patterns. At UCSF, we have around 15,000 consented participants, and of these participants, there are around 3,000 with a blood biospecimen. We then used CoPath, which is a pathology database at UCSF, to match our participants who have blood biospecimens to the biopsy history at UCSF. We then further selected for patients who have had a blood draw within 24 months before the biopsy. So the blood draw is the biospecimen collection. This yielded 130 participants, and of these, around 15 had diagnoses of invasive breast cancer, 7 with DCIS, and 14 with atypia. The current phase of our project, our hypothesis to be tested is that breast cancer-specific oncRNAs will be present in the biospecimen samples from the 22 patients who were diagnosed with DCIS or invasive breast cancer and absent in the 108 patients who received a benign biopsy. So these are proliferative changes with atypia, proliferative changes without atypia, non-proliferative changes, or normal tissue samples. The cohort selection has been completed. It is those 130 individuals who had a biopsy within 24 months after their blood biospecimen collection. And in the next phase of our project, we will send the samples to XiBio to evaluate for the presence and absence of breast cancer-specific oncRNAs. This is a very exciting project because liquid biopsies can, in the future, serve as a non-invasive means for early cancer detection and can alleviate patient burden, both psychological and physical, as traditional biopsies are often very painful experiences and can cause a lot of anxiety for patients. These tests can also be used for post-treatment applications, and we can look at oncRNA burdens as a predictor of survival. There's also the possibility to diagnose earlier in comparison to ctDNA. So some of you in the audience might have heard of circulating tumor DNA-based liquid biopsies. And those DNA-based approaches rely on the shedding of dying cancer cells. So ctDNA has lower abundance, especially in the earliest stages of disease. So oncRNA-based liquid biopsies have the possibility to diagnose even earlier. I would like to acknowledge the BCC Intern program, as well as the UCSF Breast Care Clinic and the UCSF Athena Breast Health Network. Thank you specifically to my mentors, Dr. Laura Vantvere and Allison Fiscalini, for all your help and support throughout the year. Thank you so much for listening. And if you have any questions, please feel free to email them to me. My email is Natalie, NATALIEESKIM@gmail.com.
Okay. Fantastic. I can maybe ask a question to both, one for Laura V and one for Allison. Natalie, first one, I'll start with you, Laura. Can someone give Laura the microphone? So I would say that, everyone's interested in these multi-cancer early detection tools, some of which are serious vaporware. But one of the problems is they can be expensive and problematic. And so it's so interesting. I think this is one of the fun things that happens over in a place like this is 3 years ago, the oncRNA wasn't even a thing. So this is all something that's come up. What do you see as the real advantage of something like the oncRNA test? What makes it so much more desirable than, say, the circulating tumor DNA?
Yeah, I think actually Natalie alluded on that already, that if you do circulating tumor DNA, first of all, you need to understand what are the mutations in a given tumor. And whereas that is, you can predict it more or less if you have, if you would want to detect early colorectal cancer or lung cancer, because they have a lot of common mutations across all of the tumors. But in breast cancer, that is not the case. So you have to sequence the tumor. That also makes it more expensive. So here the oncRNAs are just appearing in the blood. And what XI Bio, funded by Hani Goudarzi, a UCSF faculty, does is that, or takes advantage of, there are really thousands of oncRNAs, regulatory RNAs in the blood. And they have data now that those are even different if you take a patient who's already diagnosed, then the oncRNAs in the blood for somebody with a hormone receptor positive breast cancer is different from the ones that are triple negative, for instance. And so I think this is much more generic. I mean, we have to see if this is
Works,
what
yeah.
it's supposed to, we think it will do, but we'll see.
But it's something that could be not thousands of dollars, but 100 or so, and a tiny amount of plasma or blood, right?
Yeah, so they
That
do
makes
like
it-
do deep sequencing in the blood, so that costs money. But we have to see. There is no price set yet, but it will be cheaper than that you first
Infinitely,
have to
infinite, I mean, an order of magnitude
Yeah.
cheaper. So it makes it feasible for screening. I think that, a lot of I mean, this is one of the things that just is so irritating to me, and why I think everyone needs to have some sense of cost effectiveness analysis and what that means before you even think about or propose adding something to an early detection program. You have to understand that a test like mammography that is increased, even the increase from $150 to $300 every other year, has increased the cost. So, I mean, we're screening a population is like $12 billion to screen like 70% of the population in aggregate. So if you started adding a test like this every year, that was thousands of dollars, we would be spending more than the annual Defense Department budget.
We're
So
starting now in our UCSF cohort with a very specific subset. And if that is successful, we'll move to the UC-wide Athena cohort. And we can also think about what to do in wisdom.
I'm going to ask Allison about that in a minute.
And one of the things that I really would want to do, because we have some patients in the Athena cohort, multiple blood draws, but some of these women are still being screened without having any sign of cancer. And everybody, or actually most people, still say that they are okay to give another blood draw, but we're not doing it. So we're thinking about getting that organized.
That would be cool. Yeah. So, Allison, question for you. Let's just say that this kind of a test turns out to be reasonably inexpensive, but not totally cheap, maybe more than a cost of a mammogram. How might we think about incorporating something like this in wisdom? And is this something that we would want to do for everyone, or would we want to be more selective in our thinking about it?
I think we would want to be more selective and maybe identify those people who are at highest risk first.
Good answer.
And then to give them additional testing.
Right. So it wouldn't. So the risk assessment would be first.
Correct.
But one of the places where we have real trouble, honestly, is predicting predicting the kinds of cancers we see in I-SPY. Does anyone want to hazard a guess of how many of the patients in I-SPY, right? This is a trial designed for stage 2-3 breast cancer, right? If screening was perfect and worked really well, would we have a trial like I-SPY? No, because no one would get stage 2-3 breast cancer. So who wants to hazard a guess as to how many of the patients in I-SPY 2 actually show up because they have screen detected cancers? Okay, let's see a show of hand. How many people think it's 100%? We know that's not the answer. How about 90%?
Still don't understand the question.
The question is what percentage of the patients in the I-SPY 2 trial with these faster growing, higher risk tumors actually are found by mammography screening? So it's not 100%. We obviously just told you that. How about 90%? Anybody think it's 90%? How about 80%? 60? Yes. 50? 40? 30? You have to vote. 20? 15? That is my point. It doesn't work for everyone. We got to have, that's why we're doing the wisdom study. You know, it's like, we got to do better. Got to do better for the fast growing tumors that are actually the most lethal cancers. All right. Is everybody hungry?
Wait, I have a question. Can you hear me?
Yes. Yes, we can. Yeah.
So as you know, Laura, and I don't know about the rest of the crowd, I am a skeptic when it comes to these blood-based assays. However, there is a possibility that these will be better at detecting the more consequential cancers, i.e. having better specificity for the cancers we care about. And
we hope so.
Not as good or less sensitive for the inconsequential cancers that we're already over detecting and over treating. So I wanted to make that point. And I also wanted to make one more point, which is if a blood-based screen is a way to get women who are currently not screening into the system, then that's a benefit all by itself. So those are my 2 points.
And that's Andy Borowski, our pathologist extraordinaire, who will hopefully be here in person soon. And those are excellent points. And, you know, where we could test it are the people that in the cohort that we think are at high risk for developing these high risk cancers. I wouldn't want to do it to find more of the people who are at risk for the slow growing cancers. I don't think we need more help in finding those patients. Anyway, all right. So Francesca, you want to give us some instructions for lunch? Are we just all walking across the street? Everyone follow Francesca. Okay. And interns, but you eventually don't forget your presence from Ron Balasanian back there. Fantastic morning and fantastic and huge thanks to Anne Marie, who isn't here in person, but is on Zoom. So I want to start our afternoon session with our new intern standing up and just introducing themselves and saying what project they're on, because some of our folks here, as Jessica was saying, she, you know, and Ron and all the others haven't had a chance to see, you know, who you guys are and what project you're on. So let's start. We'll just go right around the room. Yeah.
Hello. I'm Simona, and I'm coming over from UCLA. I am taking over the Cooler Heads program, which is essentially like a more patient-focused, portable cold caps device. And then I am also doing psycho-onc stuff, so like the BCC cafe, some support groups, and then hopefully when Dr. Morgan comes back from her leave, I can also start doing some music program stuff. And it's not actual music; it stands for, what does it stand for?
Well, it's actually psychosocial sexual health for women. I forgot what the acronym is, but making music out of your life or something like that. That's it.
Yeah, exactly.
So, yeah. And actually, I met a dermatologist from Columbia who actually came up with the molecular understanding of primary alopecia that women get and a treatment for it through JAK inhibitors, who actually gave me the idea of a cream that you can use on the head to preserve the hair. So we're going to be looking into that shortly. Angela. Okay, awesome.
Hi, I'm Taylor and I'm coming from Duke, and I will primarily be working on Wisdom Project as well as the Athena Breast Health Network, and then also a bit on Rise Up.
Thank goodness.
My name
Gird
is
your
Millie.
loins. Okay, yeah.
Sorry. My name is Millie. I am coming from Georgia Tech. One fun fact is that my sister did this program, so it's very fun to see some faces where I've definitely heard Paige.
Yeah. So definitely some names that I've heard for years, and now I see the faces, which is very fun.
Those of you who have siblings, make sure you do a good job so your siblings can get in.
I know, no pressure at all for me, but it's okay. But I am working on OneSource, which is awesome. I love to organize stuff in color code. I've already done that so far here. So I feel like it's a great fit for that. And then I'm also working on ClearEdge, which is a device kind of trial. So very excited for that.
Okay.
Hi, everyone. I'm Nandini. I'm coming from UCSD, and I'm working on the Wisdom Project, the like Flex registry stuff, and also helping out with Rise Up as well. So, yeah.
That's it. I was just going to ask who's doing Flex. I have someone you have to enroll in Flex. I'll tell you in a minute. Yeah.
Cool.
She'll be in clinic at 3:30, so we can go see her.
Hello, everybody. I'm Chaley Park. I'm from Wash U in St. Louis, and I'm mainly taking over Rachel's role in the DCIS immunotherapy trial.
Chaley, oops. Is today your birthday?
It is.
Everybody, happy birthday to you. Happy birthday to you. Happy birthday, dear Jaylee. Happy birthday to you. And many more.
I've been very impressed by the harmonizing.
Oh, that's just the beginning. Okay.
Hi, everyone. I'm Michelle. I'm from Florida. I'm working on the Do-Evade trial, working on the UCSF Health website so we can update, revamp our website for breast cancer patients, working on the Taste for the Cure conference, pathology working group, and Laura's social media.
Oh yeah. Oh, so and actually, don't forget, we actually have to do something for the surgery website and move them out. I don't know what we're going to do, but something.
Noted.
Okay. Okay. Great.
Hello. Ooh, yeah, I'm loud. Hi, everyone. My name is Sabrina Yakubi. Sabrina is like Sabrina, but with no A at the end. So that's me. I went to UC Berkeley and I recently just graduated. I studied molecular and cell biology. So fun fact about me is for the better half of the past year, I was in the lab over 40 hours a week micropipetting. I really loved that, but now I'm on the iSpy trial, so no more wet lab research for me, and I'll be a clinical research coordinator on the chemo arm, and ideally I'll be here for 2 years, so you will get very used to my face. Nice to meet all of you.
Jessica, wave your hand. So this is the person. Get exchange cell phone numbers. So when you need an FTV for your preliminary return of results, which I'm sure you already know about, yes, that you can just call Jessica and get that. Okay. Biopsies with Lamorna. The queen of response predictive subtypes, and Christina on the phone for that. Okay. Next
member of the iSpy team.
Hi, everyone. My name is Sarah. I'm from Princeton, and I also studied molecular biology and did a lot of wet lab research like Sabrine. I'll be working on the EOP arm of iSpy, as well as a few other projects like ePro and RCB.
Hi, my name is Lorraine.
Yes, Christina Yao, our primary statistician. And then I think we saw Sandy there for a minute. Let's see if we can get him too. Go ahead. Go ahead.
Hi, my name is Lorraine. I'm from UCLA, and I was born and raised in Hong Kong. And fun fact, I actually also worked in wet labs. I worked in 3 wet labs before. But yeah, now I'm very excited to be working as the clinical research coordinator, and I'll be working on the recast trial.
Okay, good. Actually, Christina's also from Hong Kong. We've got a whole cohort.
Hi, everyone. I'm Alyssa. I'm from the Bay Area, Palo Alto, so not very far. I went to Cal Poly in San Luis Obispo, and I'm going to be working on the chemo arm for iSpy.
Hi, everyone. My name's Marcello. I did my undergrad at UC Irvine, and I just finished my post-bac year at UCSF here. And I'll also be working on the chemo arm for iSpy.
Don't forget to exchange phone numbers, Jessica.
We'll save that, Laura. We're not going to give my phone number the first week.
Oh, yeah, definitely, definitely. Start right from the beginning. Yeah.
Hi.
And then won't abuse it.
All right. Hi, I'm Michael. Just wrapped up my master's at UC San Diego. And I'll be working in oncoplastics under the direction of Dr. Marissa Piper, in improving breast reconstruction outcomes.
And working on microbiome stuff. Yeah.
Yeah, exactly.
Okay. Are we good? Have we missed anybody?
Alondra might be in the restroom. And
Okay.
yeah, might be online. Is Olivia online? Oh, Olivia might be online.
Olivia, are you online? Let's see.
I don't see her.
We have Santa. We had Anne Marie Halata is online though. I see her. Anne Marie, our she's trying to hand the reins over to Francesca, but trying to keep her from doing that. Okay. And we have Sandy Borowski online, our fearless pathologist from Davis. And Mike Campbell is online. Mike, can you, yeah, there you go. Immunologist par excellence, Lamorna Brown Swigert. She keeps all those specimens organized and sent out to all the right people, without which there would be no I-SPY specimen sample of hundreds of thousands of samples. Let's see. Susan Colin, who's working on our breastcancertrials.org. Let's see, who else do we have? So Serena, you're gonna present remotely. So you'll get a chance to introduce yourself shortly.
Yeah.
Sarah Venters is working with the with I-SPY and the pathology working group. Sarah, can you
Hi,
wave?
I'm here. I am. I'm just trying to turn the video off. Hey,
Okay,
here I
there
am.
you go. Great. And is it? Oh, okay. Michelle's being our tech on the side. Okay, great. And then Danielle.
We'll be working with Alondra and supporting Safi as our next presenter.
Okay, fantastic. And Adam Asara is our IT guru who's been working with you. Adam, wave and say hi. There's Adam.
Hello.
Excellent. We're gonna make it. We're gonna implement OneSource in the clinic this year, right, Adam? Right?
Absolutely.
No, it actually isn't. That's vaporware. It's there in my mind, but we're gonna make it happen and for real. Yeah, for real. All right. So who else do we need to introduce? Cindy, you want to wave hi? Cindy is here, help to onboard most of you. Cindy, you want to wave and say hi? Maybe not. Okay, we're going to get started. Okay, Daniel, thank you for being on, and Safi, we're going to call you up to get started on the afternoon, talk about decision-making around germline testing. And Daniel, we have lots of things to share with you through wisdom and other things.
Cool. Hi, everyone. My name is Safanat Sumra. I also go by Safi. One of the most important lessons that I learned this year is that you shouldn't always be comfortable with what's the standard. Things can always be improved. So yes, keep questioning and keep improving. Whether it's in patient care or research, you could always engage in quality improvement. And where I'll be going, I'll be joining some of my fellow interns at UCSF School of Medicine starting this fall. And right before we left for lunch, Laura had mentioned how the Wisdom study is working to personalize breast cancer screenings. One of the data points that they use is data from genetic testing or germline testing. And today I'll be talking about decision-making around germline testing for cancer patients. Oh, I see. So some of you may have taken a genetic test before. A germline test is essentially a genetic test that's looking for the inherited changes. So these are changes that can be passed on through genes. And some of these changes can lead to certain conditions, including cancer. In the case of breast cancer, about 5 to 10% of all cases are hereditary, so they can be traced down to such inherited genes. And there are a couple of reasons why we may want to consider germline testing, especially if you have cancer. It can really open doors to more targeted treatments. So let's say you do test positive for the BRCA1 and 2 gene mutations, then one of the therapies that you may be recommended are PARP inhibitors. In addition, it can also help guide cancer screenings. So if someone does test positive for the BRCA gene mutations for prostate cancer, the recommendation would be to be screened earlier. And in the Wisdom study, again, is using data from genetic testing to personalize screenings to the person's biology. There are potential downsides. For example, some patients do have some fear and anxiety around the results of their genetic testing. And if they do end up testing positive, it can cause some stress and strain in the family. And although there is a federal law which protects against discrimination based on your genetic test results, they can still be factored into decisions made around disability, life, and long-term care insurance. So these tests were specifically for the BRCA1 and 2 gene mutations. They first became commercially available back in 1996, so almost 3 decades ago. And back then, they were rather expensive and not as accessible. But fast forward to today, we have these more direct-to-consumer tests, and these tests are a lot more affordable, lower in costs, more accessible as well. Despite all the benefits, the affordability, and the availability of these germline tests, only 6.8%. So there was a study back in 2023 which found that only 6.8% of about more than 1 million patients who were diagnosed with cancer, and this was in California and Georgia, they underwent germline testing. And if we looked at the specific cancer type, prostate cancer is down at 1.1%. And for women with breast cancer, 26% of them received germline testing, which is relatively low given the number of people who are eligible to receive this test. So really, the question that I want to explore today is, what are the factors that are influencing a patient's decision to take a germline test? Why are these rates so low? Are they considering the pros and the cons? What's influencing their decision? And this year, I had the opportunity to explore that through a study looking at veterans with metastatic cancer and how they make decisions. So this was a mixed method study with the goal of identifying decisional needs and addressing these unmet decisional needs in veterans. And I'll be focusing primarily on the more qualitative aspects of the study. So we conducted 2 semi-structured interviews, once after they discussed germline testing with their oncologist, and then once after they were disclosed the test results. A total of 31 veterans. We interviewed a total of 31 veterans, and then all of these interviews were coded using thematic analysis. So just to kind of give an overview of the results, sorry, that's a overlay formatting, but 27 of them did agree to receive a germline test. 4 of them declined. And regardless of their decision, there were some common themes across all of these veterans. So what were some of the things that they understood correctly? What were some of the gaps in their knowledge? And even the ones who did agree, the 27 who did agree, had a lot of gaps in their knowledge about germline testing. There were concerns about whether or not surrounding their decision to take the test. And then for the purposes of this presentation, I will mainly focus on the barriers and facilitators that they faced in making this decision. So facilitators, things that really helped the veterans make a decision about germline testing. So having a background in science, being able to receive adequate information from their provider, having social support from their family or friends, trusting the VA healthcare system, these were all factors that really helped them make a decision. On the other hand, there were a lot of barriers that they faced as well, some things that hindered the veterans from making a decision. So not having adequate information, facing life stressors like poor financial circumstances. And then some veterans also cited how there was this mistrust in the healthcare system because of how healthcare has treated people of color historically. So just to look at some examples, this specific veteran cited how his best friend was there to really support him throughout his appointments, how she helped him fill out paperwork, and that he would have not made a decision without the support of his friend, his best friend. Not all veterans have this form of social support. So this specific veteran mentions how he used to be homeless. And when you don't have a roof on top of your head, genetic testing is likely the least of your considerations because you lack access to basic medical care. So this was a barrier in making a decision about germline testing. Another facilitator was just being counseled by your provider, so receiving enough information about the pros and the cons that they felt comfortable making a decision. But at the same time, even the ones who did agree to take the test, they mentioned that they weren't quite educated on what the test was, even after their discussion with their oncologist. So they mentioned how they lacked detailed information. So considering all of these, and these are just some of the barriers that I've mentioned, but considering all of these barriers and facilitators, we are currently working on implementing a decision support intervention that we worked on. And this includes a health coach who will prepare the veteran prior to their appointment with their oncologist, an audio recording of the actual consultation, as well as an informational handout or a website, whatever's more accessible to the veteran. And this is the screenshot of the handout, which just really goes over all of the information, all of the considerations around germline testing. Ultimately, the goal is to really ensure that more patients do have the opportunity to benefit from germline testing and potentially even improve the participation rates. With that, I do want to acknowledge my amazing mentor, Daniel Kwan. Thanks for joining us today. My mentor team, Laura, thanks for your wisdom, no pun intended. My supervising team, and of course, my fellow BCC interns. Thank you so much.
You know, it's interesting. I was just reflecting on this, that when BRCA 1 and 2 got cloned in 1996 and 1997, so Dr. Lapati, Fumia Lapati at University of Chicago, and I were working on these ways in which we could bring it into the clinic. And she had this slide. We were trying to put a registry together, which in their infinite wisdom, the NCI decided not to fund. But we had a slide that talked about how you were taking an experimental test and shepherding it for a while until it could become a standard clinical test. And Laura V, actually, when she was at the NKI, also ran a germline testing program. And so I think there was a period of time when this was experimental, we didn't know, but now things have changed, right? And so I think that, or unfortunately, based on that survey, not as much as they should, but nearly 30 years later, is it time for us to stop thinking about the scourge or difficulties of genetic testing and sort of make it more of an opt-out because there's so much potential benefit and there are actually treatments that are, things that you can do. So what do you think about that based on how, what your experience has been talking to people?
I think even if we were to make it an opt-out system, it's important that they do know the potential downsides. So I think as long as we can ensure that they are being properly counseled about everything, then yeah, I think that could be a way to increase the rates and make sure they're getting the most out of germline testing.
Or the most out of their cancer testing. I mean, I hope in the next year, we're about to start an arm of iSpy that has a PARP inhibitor in it that might be a way to treat everybody. I mean, it could be amazing if this works, but everything always works before we test it in my mind. But anyway, you know, but I think perhaps the most striking thing about what you see is that you have to take into account people's circumstance, right? And that people's priorities, even screening for cancer, even if you're really high risk, if you don't have a roof over your head, you know, it's not even your health care that you're worried about, it's your day-to-day existence, right? Yeah. So Jeff.
Laura, you know, I wander into these domains that I don't understand, you know, I don't fully understand the biology and all that kind of stuff. And I ask simple decision-making questions, and I'm often shocked by the answers. So in this case, you know, I asked, well, what's the benefit in terms of, let's say you are test positive, and now you have access to personalized treatments based on the germline test results. So what's the survival benefit? And, you know, I understand that sometimes you want to innovate and experiment ahead of a lot of survival benefit. But in this case, Daniel can speak to this. There's not a lot of survival benefit, maybe a 4-month change in life expectancy. So
I don't think you're thinking about it properly. When I think about genetic testing, is the benefit only for that person and that cancer, Safi?
It's also for their family, for in terms of enabling early detection.
yeah, I hear that. But as a patient, I also want to know. So the point is,
there is nothing more life-saving actually than oophorectomy and a BRCA1 carrier. It's more so than any organ transplant or anything else. I mean, there are some real benefits, not common, but.
Laura, I hear you. And as a patient, I absolutely need to know the absolute benefit for me of any procedure. And that is something just I want interns to understand, I want everyone to understand. The entire, you know, healthcare enterprise lives on relative risk reduction as a metric and shies away from talking about absolute benefit in virtually every aspect of healthcare. So you just have to always ask that question, and you want patients to know. Now, there can be all kinds of other benefits that people want to consider, but the first question ought to be like, what's the absolute benefit?
Daniel, did you want to say something?
No, yeah, I agree. And I don't know what the benefits of PARP inhibitors are, and specifically breast cancer, I'd be curious to know. But, you know, Jeff is right. You know, technically the trials we have currently, olaparib and really advanced prostate cancer, it's about, you know, 7 months or so when we take into account various, you know, statistical factors. But, you know, this is an average. Some people don't benefit at all. Some people benefit a lot more than that. And so it is a wide range. And, you know, it's tough to really, you know, distill it down to a single number. It's not really for us to decide what is significant or not. You know, for some patients, a little bit is quite significant. So it's not really for us to say. But I think at least informing people of the facts of these numbers, yeah, that is important.
Yeah, and surely you know better than to say that there's an absolute benefit for every single patient, right? Because there's a range, right? But range. I would say on BRCA1, so I'm talking about absolute. Okay, so in absolute terms, I'll just give you one statistic. BRCA1 for sure. Okay, you have an 85% lifetime risk of getting breast cancer. Okay, you can have prophylactic surgery that brings that down to 5% if you choose to do that. We know that if you have a cancer and you have residual disease and say you have a 30% risk, these drugs drop that risk by half. So like 15% absolute benefit. We do so many more things for that. We know that as a standard that these PARP inhibitors in the setting of BRCA1, BRCA2, PALB2 as a single agent achieve a complete response in 60 to 70% of patients without chemotherapy.
So that 30 to 15% you just mentioned?
That's absolute, not relative.
Okay,
it's a 50% relative risk reduction. So if you—
What's the outcome? What's the outcome? What's the outcome?
Metastasis.
Metastasis.
Okay, which turns into survival.
Let's talk about survival. Why are we talking about intermediate outcomes? Let's talk about survival.
No, okay, we'll talk about it at dinner, but it's not, yeah, I mean, I think it's such a small number of people who benefit, but these are not zero benefits. This is like one of the few things where preventive interventions make a difference. There are drugs on the market that we know are coming that are absolutely going to be effective, and they're the standard of care for adjuvant therapy. And they're actually by themselves very, very well tolerated, and they provide real benefit. You know, we give chemotherapy for a 3% benefit. Most people choose it for even 2% benefit. These are things for like 15% benefit to avoid metastatic disease.
People, when they understood that it wasn't, when we translated 2 to 3% benefit into absolute survival.
I'm not talking about 2 or 3. I'm talking about 15%.
Right.
So this is trust me, I know this. These are not actually marginal things. Now, for prostate cancer, we have no idea if this would make a difference for someone with a prostate cancer. We don't know that. It hasn't been done. But if in fact, in the next year, we learn that this works, this may be something that ought to be applied to anyone who has a BRCA tumor to have a non-chemo. I mean, I would say when I look at the landscape, when I see the potential of a drug, if this combination that we're testing is successful, like 90% for mutation carriers, I would say that those people should skip getting prophylactic surgery. I mean, that's a huge deal.
I think
and
that,
not dying like their family members.
I think that actually like identifying a BRCA mutation, I think that's a scenario where I think it's like pretty easy to justify benefit to patients. And of course, some patients are not going to, you know, want that information or want to act on that information. But to me, one of the bigger concerns about something to think about when broadly applying genetic testing is when you identify the low and intermediate penetrance pathogenic variants, because that really puts someone in a challenging situation where, the benefit of prophylactic surgery or even high risk surveillance or screening, which they're going to have to do for the rest of their life, may be a little bit harder to justify. So I'm not saying we should do it, but to me, that's an area
that I 100% agree. And in fact, it now turns out that half the CHEK2 pathogenic mutations that we consider pathogenic really don't increase your risk at all. So I think but one of the things that we don't know until we do more testing is we don't also know as much, and that's part of the issue. So I mean, look, we're spreading it out as just a standard of care as part of the wisdom study. So we'll let you know. Stay tuned.
Because I think one other benefit is, which will increase your 30%, and even for some of those moderate risks, is that people have a risk for a second or a third or a fourth breast cancer, plus sometimes other cancer types. So as soon as you have found it, the whole management will change. And that's even more because some, as you know, BRCA has a risk for ovarian cancer. Hardly anybody is being detected in time. So if you know before that ever occurs, I mean, you have like 100% benefit, more or less.
I mean, there are, but again, it's like 1%, 2% of the population. But in thinking about screening, it is, now here you're asking about this in the setting of cancer. What do you think about it in the setting of wisdom, where we're just asking people if they want to be part of this personalized risk assessment?
As in, what are the benefits for?
Well, it's just like if Jeff's questioning it, even in someone with cancer, what about the average person on the street that we're doing it for routinely now?
I think it's worth considering in terms of routine care. I don't see why not.
Well, time will tell. We'll see. And again, it's one of the things, if you have the ability to find people with the very, very highest risk, you know, we're screening everybody as if they have the same cancer, right? Telling everybody to get screened. Maybe we should be focusing more on just the very highest risk people. To be determined. That's what wisdom's all about.
This research needs to be continued.
To be continued. Yes. Yes, but make sure that you ask your patients also about their circumstances, their social circumstance, right, before you assume they've got the capacity to sort of think about all these other things. For sure. Okay, we are moving on. Thank you so much, Safi. And Abigail, come on up and tell us all about organizing information and whether it's even possible.
Hi, everyone. everyone. My name is Abigail, and what I learned at the BCC this year, I actually learned it really early on, and it stuck with me ever since I heard Laura say it. And it's just don't let perfect be the enemy of good. Really stuck with me because I know that oftentimes a lot of us we want to launch things as best as we can, as best as possible, and so that kind of may limit us from actually moving forward. But I think it's a really important lesson to learn that sometimes like it's okay if things are not perfect and you learn along the way, because ultimately that's how things grow and become better. So yeah. And I will be going to medical school next year at the Icahn School of Medicine at Mount Sinai. So really excited about that. So Safi just gave a great presentation about how we can better improve clinical decision-making for patients. And so I kind of just want to shift a little bit and think about this in the scheme of providers in particular. And so I will be talking specifically about how we can better organize, clinical information, better organize patient clinical information to support patient care and research. And I've been working with Dr. Esserman in collaboration with key people at the Quantum Leap Healthcare Collaborative to examine how we collect, store, and visualize pathology data. So, so recording, reporting, and managing pathology data is an integral component of patient care and trials. And as breast cancer care has evolved and with the rise of neoadjuvant therapy, there have also been increasingly more events within an episode of care for any given patient. And with that, there are also at every point in this process, more data is being included within a patient electronic health record. The challenge, however, the challenge, however, is that this data is being repeatedly entered into the EHR on multiple occasions. However, oftentimes not in a way that's easily accessible or organized by the different, and it's not easily accessible by the different parties who use this data on a regular basis, including clinicians, researchers, and cancer registries, but not limited to those parties. And so, imagine not only how laborious this process is to enter and access this information, but for some of you, you might also identify with feelings of frustration when trying to identify where a comprehensive record of a patient's diagnosis and treatment. So what we have been thinking, oh my gosh, sorry, I keep thinking that I mess up my slides. So what we've been thinking about here at UCSF with Quantum Leap is a framework where we can use one source, a tool designed to automate the flow of structured electronic health record data into external systems to automate the generation of a clinical timeline for any given patient. Specifically, with this project, it's in regards to pathology data. And we imagine that a framework like this would help to prevent confusion between repeated entries into the electronic health record, serve as a critical resource for informing clinical decision-making, and improving registries that extract data and also serve as a resource for data. So as it stands, data capture for populating databases is a pretty manual process, at least here. A pathologist will generate and enter patient information based off of a CAP required synoptic report, CAP being College of American Pathologists. And a PDF of this data is then loaded into the electronic health record, and a data manager such as an intern like myself would then extract that data, putting it back again into text fields in an effort to make it discrete and within a Word document. And that Word document is what we use for our weekly pathology sheets that are reviewed at Tumor Board on a weekly basis. And after that is reviewed, it is pulled into an external database in Excel after a macro is run. And this is just a visual example of what the pathology sheets look like at this time. There is a section for invasive and non-invasive disease where we can capture essential elements from the synoptic notes that are of interest to clinicians. And this data is pulled, every single field here is linked to a column within Excel where this data is organized. And every row is specific to a patient or a separate event for a given patient. And as you can imagine, there are problems associated with this manual entry. The first is that it's kind of inefficient, right? You're putting in data once in partially in a discrete manner, and it's being uploaded into the EHR. It's no longer discrete, and someone is extracting that data again to make it discrete, but now it's in a completely, it's not in the most organized way possible. Another thing is that it's very error prone because of just human error. So there can be misspellings for patient biographical information that's identifying, also for elements such as histological data, and numerical data as well, such as measurements. And also there may be inconsistencies between data managers who enter this information because of the turnover within the role. So what we envision in order to improve this data capture is the utilization of Open Clinica, the electronic data capture system, which would enable for these entries these elements to be collected in a more structured way. So ideally, a data manager would organize elements from the pathology report found in a patient record, and providers would also serve as collaborators on this form. And they would add other essential elements that are of interest as they become available. And by utilizing one source, this newly interoperable information can then be pulled to create a clinical event timeline for a given patient based off of the entries that are present within the database that have been based on the entries that are present within the database through the Open Clinica data capture system. And so we've been building this alternative tool so that we can begin to test a new way of capturing data. And as you can see here, we have two different forms that are currently in development, one of which has a more structured way in order to collect data on invasive and non-invasive disease, and specifically for pathology. And we also have a form designed to collect systemic therapy as well that would be incorporated into the timeline. And this form also includes the capture of other essential elements that we're not currently recording, such as mammoprint, oncotype, and RC, residual cancer burden. So based on the data entered into Open Clinica for a specific patient, an automated timeline of the treatment history and the cancer biology would be generated for a patient. And this is just an example of what that would look like, given real patient data that we've tested, what we're using to test the visualization of this. So a provider can see just how there may or may not have been a change in the tumor biology or the characteristics for over time, which can help to inform clinical decision-making. And by enhancing the interoperability of the data within the pathology synoptic notes, the information can be organized within its clinical context for any patient within the system. And this is important and clinically relevant because the transition to the proposed system would help us to mitigate error in data reporting while also saving time. And it would help us to retain contextual data while supporting a repository, a data repository. And this would ultimately will provide context to inform clinical decisions that providers are making on behalf of their patient, ultimately supporting the delivery of higher quality patient care. Yeah, and I just want to appreciate my mentors that I've been working with throughout the year, Dr. Esserman, Adam, who's here on the call, I believe still as well, and Amrita and Ron, who are all involved in different projects that I've been working on here at the BCC, and also my friends here. Yeah.
Well, this just seems so logical. Why is it so hard to do?
Because people don't want to change the way they're doing things.
Or they can't. And then who else is entering, who else is copying the pathology data in clinic?
Wait, who else is capturing?
Yeah, is just because we see it there. It's a set of notes from me, and they're copying it. And then they're writing it again into a note. And every provider who sees this patient is copying that data over and over again, right?
Mm-hmm. Yeah. And so it's being repeatedly entered into the EHR, but there's no like central place where someone can identify it.
Right. And who's the source of truth when they're entering the pathology data?
the patient.
No, who's, well, not really.
Well,
I mean, pathologists, right?
well, yeah, but
I mean, they're interpreting it, right? They're the first, who's the first person to enter the pathology data?
pathologists.
Right. So if we could figure out how to make that structured, and then that's, we could pull that for any time anybody wanted, you could just write that pathology or whatever, and it would come into populating our little template, right? Wouldn't that be a beautiful thing?
It would. We need permissions from.
Yeah. I don't even think the permissions are as hard anymore. It's just like, we're going to do it this year. Okay. What do you think is the most important next step in this whole, in making this possible? You're thinking about it.
Making sure that the forms that we develop are aligned with the way that pathologists are currently entering their data. So it's a seamless transition.
Right. And it helps them. Somehow, if they fill it in for us in that way, it gets their work done and we get our work done. And we get to do our pilot. Yes, Jessica.
I think a lot about data. I'm Jessica. I interviewed you for the
remember.
internship. I love that you're bringing
the same energy that I noticed in your interview and that stood out so much to the work that you've been doing with data and databases, things that people consider really boring, but you brought that passion and it's really important. So thank you.
Yeah.
Well, thank you.
Imagine if we could pull all this in automatically to iSpy. It would, and it's very possible. It's technically not hard. It's organizationally very hard, right? Yeah, but we shall overcome.
Some of us remember when there were paper forms and files, like patient charts that were physical things.
Yeah, and I have to say that's only a little bit better than that. Not much. Just a little bit, but we're going to make it a lot better, right, Millie? Okay. Thank you, Abigail. That is awesome. We aspire to better. All right. Kevin is going to tell us about what he learned and little fun facts about Kevin, and he's an extraordinary musician, cellist. Yes.
Hi, everyone. I'm Kevin, and today I'll be talking to you guys about clinic-mediated trial matching and the UCSF pilot program that we did. But before I go on, I think the most important lesson that I learned was that it's not really a lesson, but I think when I see myself as like an attending working in medicine, I really want my coworkers to feel like family. Like I see Laura and all the other providers and staff here as a family. So that's what I strive for. So that's the lesson I learned. I'm going to University of Maryland School of Medicine next year. Super excited. And as Abigail mentioned, collecting data and aggregating data so that we could easily manipulate it, so we could easily visualize it is so important. And I'm going to be touching upon a little bit of that and how that can be relevant to clinical trial matching at the point of care. So as a quick background, clinical trials, as I'm sure most of you, or if not all of you are aware, are very important for a multitude of reasons for both patients and research. So for patients, it provides an opportunity for them to have access to personalized medicine as well as new treatments. It also allows for them to have an active role in their own healthcare and can potentially improve their quality of life. And for research or for medicine, it allows for the development of new medicines, helps understand complex or unknown disease mechanisms, and also has monumental public health impacts. And as Laura loves to say, it helps challenge and improve the standard of care. So as we delve into the current state of clinical trial matching, it's essential to understand the complexity and, more importantly, the redundancy that's involved in the process. So I'm not going to really dive into the nitty-gritty of what a general clinical trial matching process looks like, but as you can see, there's a significant amount of redundancy in the process. CRCs and the trial support staff often work in parallel with the providers doing similar things over and over again, which leads to duplicated efforts. Moreover, patients up there in the yellow often remain unaware or in the dark about their own clinical trial options, which can limit or hinder their decision-making process in clinical trial participation. So let's see. Yeah, having understood the current challenges in clinical trial matching, let's now look at how the trial matching tool or any trial matching tool can be used to address certain issues and provide significant benefits to various stakeholders. So for patients, especially the patients who are coming in outside of UCSF, so they would be like the second opinion patients, trial matching tools can be utilized to seamlessly aggregate data from other institutions. For clinicians, it could be utilized to help triage patients who are waiting to see the clinicians at the hospital. And another added benefit is that trial matching tools offer match lists outside of the home institution, so outside of UCSF or whatever institution you'd be a part of. And I think also just as important is that it creates a centralized and curated resource for the research team. So right now at UCSF or at the BCC, people are often relying on phone calls, emails, and even paper boards. And it feels like a pretty inefficient process and unstandardized process. So in order to see what the implementation of the matching tools would look like, and as well as to assess the demand at UCSF, we ran a pilot study with 3 broad main objectives. The first one being triaging patients waiting to see providers at UCSF. So the idea is that if we know that certain patients waiting to see providers at UCSF will qualify or will be eligible for a clinical trial that's open at UCSF, then they will be prioritized over other patients that may not be eligible. And secondly, we wanted to determine how accurately patients can enter in their own medical information in the patient-facing trial matching tools. And finally, we wanted to leverage the new and established tools that were developed through Quantum to determine the usefulness as well as the value in the clinic workflow. So these are the two tools that we utilized in the pilot. On the left is the trial match program that was developed by Quantum. It's intended to be a provider-facing clinical trial matching tool. Now on the right is a very well-validated and it's a tool that's been used by thousands of patients. And it's metastatic trial search, which is housed under the breastcancertrials.org. And that's a very patient-friendly, patient-facing tool that allows patients to see their clinical trial options. So this is the general clinical trial match pilot design. We basically asked the medical oncology new patient coordinator to help identify new metastatic patients interested in clinical trials. And then I would approach these patients and talk to them and help them fill out the patient-facing trial matching tool. And then I would work with Adam and Susan to help create a intuitive list and to send them back to the patient as well as to the providers, pretty similar to the way that we approach question listing and consultation summaries and patient support core. So far, we've only had one patient who's been interested in participating, and she is a 43-year-old woman with triple-negative breast cancer involving leptomeninges. She was diagnosed with locally advanced and possibly metastatic triple-negative breast cancer, and right after surgery, a CT showed leptomeningeal enhancement. So that's when she scheduled an appointment with Dr. Rugo, and that's when we found that's when we essentially connected with her. So I met up with her and helped her navigate through the breastcancertrials.org, which is, again, the patient-facing trial matching tool. And we uncovered a couple of thematic tensions. I think the most apparent one was the tension between empowering patients with their clinical trial options and giving patients false hope. So in this particular case, the trials that she was provided through the tool, she wasn't necessarily eligible for, or they were just closed or not at UCSF. So there was definitely this tension between actually helping the patient navigate through this process of potentially finding clinical trial options versus giving her false hope that that may have a overall negative impact in the long run. Another tension is the tension between increasing efficiency and ensuring the accuracy of the matches. Another one is the actual utility of the clinical trial matching tools and the practical challenges of implementation. So as we go on with this pilot program, we'll see like just how beneficial it is, and if that benefit is going to outweigh the necessary work that's going to be needed to actually implement it in the clinic. And the final tension that we identified was the tension between proactively suggesting trial navigations to patients versus patients actually initiating this conversation with us. So yeah, that's something that we're planning on exploring. And I think, Jeff, we haven't really talked about this yet because we thought of this in our Monday faculty meeting, but yeah, I think the question that's immediately on my mind right now is how might we leverage existing workflow and existing architecture to have the right information for patients at the right time at the point of care. So like how can we leverage the interns? How can we leverage the patient support course so that we could anticipate and we could actually show up to appointments or help patients show up to appointments with a valid clinical trial list through PSC. And so the pilot right now is in phase 1 where there is no integration between Epic and the actual tools on Google or just on the web. But ideally, there would be just seamless interoperability between Epic, REDCap, and our OneSource trial match system. And this is just what a mock-up of that would look like from a technical standpoint. So all the information from Epic will be auto-filled into CT Match under the OneSource tab, and then the provider or one of the interns can click on it and help go through it with the patient and send it to them prior to the appointments. I'd like to thank you all for such an amazing and magical experience these past 2 years. And these were some of my favorite moments. Yeah.
So Kevin, we're really at the point of knowing now a really good way to implement this. Why do you think it was so hard to get to this point? Seems so simple.
Yeah, it does seem very simple. I think the first thought that comes to mind is that people don't really like to change, especially the way that they've been working for years and years. And I feel like we have the burden of proof to show them that this is going to be so much more efficient and so much more accurate. And if we don't have that, if we're not really strong and bona fide about that, then like it's really hard to get people to change.
Yeah. And maybe the trick is trying to get it done before the physicians ever get involved at all, like working with the nurse navigators.
Absolutely.
And just having all this stuff done as a service. But again, if it's, I mean, one of the reasons why I wanted to have you do it where you're talking to people ahead of time is that I believe that the uptake of a physician in clinic and a busy appointment doing this is going to be, I think that's going to be high or low.
Did you repeat that?
Yeah. So we were going to compare it to whether or not physicians are willing to do the trial matching. You think they're going to be willing to pull up that tool and fill it out?
I think if it's integrated within Epic and it's a matter of like a couple clicks, then I don't see why they wouldn't. But yeah, that would be an optimistic way of thinking.
That's optimistic, maybe. But if it was already done and it was integrated into Epic, probably even better.
Exactly. Yeah.
So it's just, trying to find the right way to do things. Then we come back to really all the way to our first project, right? Astrid's project, or one of the first discussions of this is like, look how hard it is to set up a registry where you get 10% of people into your registry, right? Yeah. So what if we just did this for everybody? We had all the data in, you click these tools. And this was, again, clinical trial matching is just one of the things it's an app you can run if the data is in. The lesion in the system is the lack of consistent entry of data into a system that makes it accessible, useful, and easy to apply. right? That's otherwise your job would have been super easy, right? Yeah. All these pesky things in the way, but we will solve it. Okay, awesome, Kevin. Great job. Hey, Serena, are you presenting on Zoom?
Yes. Hello, everyone.
Okay. Don't forget to start with what most important lesson you learned and where you're going next year.
Good afternoon, everyone. My name is Serena Bascarao, and I'll start off by saying the one thing I learned at the BCC this year is that even though mistakes are unfortunate and often lead to regrets, it's important to remember that mistakes are also valuable opportunities to learn and grow. And as for my future plans, this coming year, I will be starting medical school at Loma Linda University, and I am very excited to be doing that. Okay, so we have just heard Kevin tell us about a system to match patients to clinical trials, which is crucial for those currently battling breast cancer. But what about patients who have successfully overcome cancer and are now breast cancer survivors? How can we ensure that they continue to thrive and stay healthy? Well, today I will introduce you to a clinical trial designed for breast cancer survivors, which I've been working on with my wonderful mentors and PIs, Dr. Michael Campbell and Dr. Katrina Whiteson. So let's explore how we can use high fiber diets to promote microbiome and immune health in breast cancer survivors. So first of all, what is the microbiome? It's defined as the collection of microscopic organisms, such as bacteria, viruses, and fungi that inhabit a particular environment. The human body itself has several distinct microbiomes on the skin, the mouth, in our airways, and the one that is particularly well known, the gut microbiome. So how does the microbiome impact our health? The microbiome is crucial for many things, including digestion, nutrient absorption, immune modulation, protection against pathogens, and vitamin synthesis, to name a few. But certain microbes have also been correlated with different diseases, such as gastrointestinal diseases, metabolic disorders, cancer, and autoimmune diseases. And lastly, dysbiosis, or the disruption of the gut microbiota, leads to increased inflammation, compromised immunity, higher infection risk, and worsened chronic diseases. Clearly, the microbiome has a great influence on health, and studies have shown that in general, a more diverse microbiome is correlated with a healthier individual. So what exactly determines one's unique microbiome composition? That would be a combination of several factors, including family genetics, the different environments we're exposed to, the use of medicines, notably antibiotics, and last but not least, the foods we eat, which make up our diet. So knowing this information, how can we take microbiome composition into our own hands and modulate it towards a healthier state? Several strategies can be employed. The first is through probiotics, which are live beneficial bacteria that can be found in fermented foods such as yogurt, kombucha, and kimchi. These can help maintain a healthy balance of gut microbes. And the second is prebiotics, which are microbial accessible nutrients commonly known as dietary fibers, which serve as food for the beneficial microbes supporting growth and activity of the healthy microbes in our gut. And the last two are fecal microbiota transplant and phage therapy, which are both very effective methods of modulating the microbiome, but can be more invasive and are not readily accessible. So with such advancements, we're getting closer to being able to engineer the microbiome to promote overall health and setting the stage for exploring specific interventions. So going back to prebiotics and fiber, there's a significant fiber gap in the United States, with the recommended daily serving being 20 to 40 grams per day for optimal health, and the average American diet only receiving 15 grams per day. A deficit like this is surely going to impact gut health. Looking more into the mechanisms of how fiber benefits our gut, we know that a high fiber diet provides essential nutrients to feed our good gut microbes. And these microbes actually metabolize the dietary fibers that our digestive system cannot, and then produce short-chain fatty acids. These small molecules called short-chain fatty acids are important metabolites in the human body that provide many benefits, including reducing inflammation, immune system regulation, and many other systemic benefits. So, our hypothesis is that a short-term high-fiber diet can significantly increase microbiome diversity and favor microbes associated with improved treatment efficacy and enhanced anti-tumor immunity. So why do we think this will work? Here are some previous studies that especially convinced us that fiber is the way to go. One observational study was done on melanoma patients undergoing immunotherapy, and it found that people who were eating more than 20 grams of fiber daily had double the progress-free survival. And another study done by our own Dr. Whiteson and her class of undergraduate students at UC Irvine involved a 2-week high-fiber dietary intervention and tracking of microbiomes throughout this intervention using fecal samples. And they also found that individuals' microbiome compositions changed by about 8%, which represents a significant increase in diversity after intervention. So for our study, we're currently enrolling participants with an end goal of 60 participants. And to be eligible, patients must be breast cancer survivors that are at least 1 year post-treatment. And the enrollment process for the study was done completely online through REDCap, and participants were mailed all the supplies to facilitate remote sample collection and a remote intervention. Our first goal with the study was to help people fill their fiber gap and meet their daily fiber requirements with the help of adding chia seeds to their diet. And the reason why we chose chia seeds is because they're a great source of fiber, they're a whole food, and they're fairly easy to incorporate into the diet. Our second goal was to test out the feasibility of this remote study design. The study period is 3 weeks, with the first week being the pre-intervention period during which participants start their daily diet tracking. And they also collect 4 pre-intervention stool samples, all on different days, and then 2 finger prick blood samples also on different days. And starting the first day of week 2, participants are asked to start consuming a total of 40 grams of fiber per day, including 2.5 tablespoons of chia seeds each day until the end of the study period. During weeks 2 and 3, more fecal samples and blood samples are collected to reflect the post-intervention. As of now, our study is still ongoing and we have not yet set the samples to be analyzed, but here's a preview of how we plan to analyze our fecal and blood samples, as well as some expected outcomes. So for our microbiome analysis of the fecal samples, we're using a method called shotgun metagenomic sequencing. And this technique reads all the genetic material in a sample and will allow us to identify microbes present, all the microbes present in each sample at each time point. And this would give us a detailed picture of the entire microbial community for each participant. And post-intervention, we expect to see a healthier microbiome, which would entail an increase in microbial diversity and an increase in abundance of short-chain fatty acid producing microbes. And with our blood samples, we will be doing a cytokine-chemokine analysis. Cytokines are small proteins released by immune cells that act as signals to help regulate the immune response, and chemokines are a type of cytokine that guide immune cells to where they need to go in the body. We will also measure various immune markers using a 48-plex panel, which includes the markers listed. And inflammation is a key part of many diseases, including cancer. So by seeing how these markers change over time, we can learn about how the effects of our high-fiber diet, how it affects inflammation and overall immune health. The expected outcomes are not as clear for this analysis because there isn't much research on how high-fiber diets affect these markers, but we could possibly expect to see inflammatory cytokines like interleukin-1 beta, interleukin-6, and tumor necrosis factor alpha decrease. But this also depends on whether they were previously elevated to begin with, pre-intervention. Okay, finally, looking at the future, if our study proves to be successful and feasible, we hope to soon expand this study design to newly diagnosed breast cancer patients and patients on I-SPY to prime them for success with their respective treatments. Clearly, microbiome modulation through dietary interventions has endless possibilities for future applications, with the potential to improve treatment outcomes across various cancer stages and types, and possibly serving as adjuvant microbiome therapy, and even maybe a general guide for future dietary recommendations for patients. As that concludes our presentation, I would like to thank my mentors, Dr. Campbell and Dr. Whiteson, and everyone at the BCC for all their guidance and support this whole year. And also, since we are still recruiting for this study, I have put a QR code here that will take you to the free screening survey for the study in case you or anyone you know might be eligible or interested in participating. And to be eligible, once again, you must be a breast cancer survivor that is at least 1 year post-treatment. Okay, thank you, everyone.
All right, so we know you can find out if you need a control group and we'll all sign up. Okay, well, that's very exciting. And has anyone, do you have any experience of people now starting with the chia seeds? Or people are working on it, right? How are they doing with that?
They're doing pretty good. I have to go over, we have a post-intervention survey that everyone's filling out, so I have to go over and see the feedback, but we have quite a few people that have finished the whole intervention and everything.
Oh, really?
Yeah.
And they did the chia seeds and they sent it all in. So we know we can do
all their
it. We can
samples.
do it. I'm missing, recommended reading. Might be time to cycle the Missing Microbes book again.
Oh, yeah.
Yeah. But you'll be close enough to Katrina that you can still work on the study. When you get some independent time to work on the study, you can join in.
Yeah.
So Michael, you're working on something. Who else is working on microbiome? Is it just you? Who else? Who else is? Oh yeah. Oh, that's right. Okay, great. This is going to be very exciting. This is, I don't know, how long have I been talking about the microbiome? About, lost track. Yes. Maybe I remember it was the Helen Diller. That was I remember the skits that was done the year of the interns when we first talked about Helen Diller. Helen Diller. Da, 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 da. What year was that? We were still at Mount Zion, yeah. So it's been at least 12 years, but who knows? Who's counting? Okay, Laura V.
I have a question for Serena. We have a graduate student from the PSPG program here, Silver Alkafai, and she is looking in the I-SPY patients themselves who are treated with immune oncology drugs about cytokine levels, and some are overlapping with the ones that you've been studying in the microbiome. So I'm wondering, probably some of your patients in your study are I-SPY 2 cancer survivors, right?
Probably not, actually.
No? Well, that's my question to Serena. Do you know that? Or otherwise, because those patients that she's been studying have been treated in the recent years, so maybe we can target them to actually enroll in this study and see how that relates to their cytokine that we previously measured in their blood.
Well, yeah, do we know? I don't think we know if they're I-SPY 2. Probably not,
Yeah,
though.
I'm not sure. I only have the participant names and their addresses, but no.
But we can maybe search for them.
We could, but
in the continuation.
yeah, because we weren't specifically targeting I-SPY patients for this.
That, but by chance.
But we will be going back. And by the way, we actually are doing microbiome on all of the patients who enrolled in the DCIS immunotherapy trial. And we have cytokines and all kinds of cytoph being measured. So we can look there. So we'll see. But we don't know, but we didn't do our fiber intervention with them, did we? No. Anyway, super exciting. Anyway, thank you, Serena. Thanks for bringing, and actually we got Serena actually from Katrina's lab to begin with. So, and that's how we keep it there. All right, fantastic. All right. All right, well, last but not least, we have a closing presentation from Safi and Astrid talking about patient support.
Okay, hello everyone. My name is Astrid and this is my partner Safi. And one of the things that we have learned this past year is that you're only going to be handed a couple of opportunities to be in front of a podium and with a microphone, and you have to make them count. And this is going to be one of them. And so we're going to talk about improving support for patients who speak languages other than English at the Breast Care Center. And so I want to tell you a bit of a background. So my family immigrated from Mexico, and on top of the fact that they never knew if they were ever going to return back to their homeland, they had to leave everything behind, including all of their family and friends. And to add on to the stressors of immigration, they also had to deal with my grandma's cancer diagnosis. And so my mom had to learn English
become an interpreter, become a caregiver, and also just be an advocate in a system that wasn't built to support patients like my grandma. And as I got older, I also had to become an advocate and support my family, specifically all of my non-English speaking family members, to interact with a healthcare system that was still not addressing all of their needs. And that is one of the reasons why my presence in medicine is why I'm here, why I do my work, why I wanted to be in the patient support corps to begin with, to bring that story and address all of the barriers that patients that are coming from an immigrant background like mine, and when they come into the clinic.
So I'm sure some of you may already be aware of our program, but the PSC, or the Patient Support Corps, it's a service learning opportunity for pre-health interns like a lot of us, which trains interns as patient scribes. So part of our role, we help patients prepare a list of questions prior to their appointment. And then we also take notes for them during the appointment, and we also make an audio recording. Now, just visualize, imagine that you are someone whose first language is not English, and you have a diagnosis of, let's say, cancer. You're primarily relying on your family members or your loved ones to translate and interpret for you, but really you're relying on their level of skill set, and maybe you don't have that sort of support with you. And let's say you don't have that support, you go to your electronic health records, and most of them are in English. Let's say they're test reports, pathology reports. And although Apex now is trying to transition into different languages, it's still limited in terms of how much content they can automatically translate. So with this project, Astrid and I have been working to really make sure that we can at least have our patient support corps services delivered in languages other than English. And by doing so, we hope to promote health equity by really providing patients their healthcare in their own language. So to kind of go over the project workflow, before the appointment, while we're question listing, we are enlisting the use of an interpreter. So, and again, throughout this workflow, we're using resources that are present at UCSF. So we're including an interpreter to make sure that the patient can comfortably communicate their concerns and questions. And then even after we have the list of questions, we are translating them into their preferred language, again, using the UCSF translation services. And then during the appointment, the intern is audio recording both the English version of what the provider is saying, but also the interpreted version from the interpreters. After the appointment, the intern submits the notes again to the UCSF translation services, and then we email both the audio recording and the notes back to the patient. So now they have them and they can use them in their deliberations, again, in their own language. And then Astrid will go over a more specific case study of how we implemented this.
And so I want to go over a specific case study of a patient that we followed longitudinally throughout her neoadjuvant therapy. And so this particular patient, she relied on her daughter to interact on the healthcare system on her behalf. And so any questions had to go through her daughter. Her daughter was the one mainly asking the questions, mainly coming up with like any follow-ups that were needed. And you didn't really hear much from the patient. But after repeated health coaching and also question listing with the patient before every single chemotherapy appointment, she started to interact with the healthcare system by beginning to ask questions to her healthcare provider, even though she was asking them in Spanish and she knew that her provider spoke English. She knew my presence there in those appointments would be to advocate for her to ensure that all of her questions are getting answered. And so in a sense, we served as a healthcare navigator by not only helping her throughout the entire length of her neoadjuvant therapy, but we also helped her come up, log onto my chart and being able to use the functionality of my chart, because we would send her resources in Spanish. And so we provided her an avenue to be able to start communicating through my chart regarding her health. And we also received feedback from her caregivers, so her son and her daughter. Her daughter expressed that fact that we were present in the room, being able to take notes and audio record allowed her to be more comfortable and present during the appointment and be able to focus on interpreting. In terms of her son relayed to us that it was really impactful to be able to receive the translated notes, because otherwise, if he was receiving English notes, he would have had to be the one translating. And he even admitted that he didn't know a lot of the technicalities when it came to like medical terms. And so that just goes to show how important these notes and these resources are, because they're the only aspect of that consult that gets sent to the patient and the patient can actually understand. They're not going to be able to go to my chart and read through all of that. But what was interesting about these particular cases and what has been very challenging for healthcare is to be able to control for the quality of the interpretation during the live appointment. And so in those instances, when I was hearing the conversation happen in English and in Spanish, I was able to nudge the provider and let the provider know to repeat certain instances because we were creating an audio recording and I wanted that interpretation to be correct. And so bilingual interns can advocate for patients during instances of misinterpretation during the appointment, but we're also establishing a pathway of accountability. Because as the patient scribe is present in those appointments, we're recording the interpreter ID, we're able to create a recording of the consult, have notes taken of what was said during the consult, and being able to escalate that to not only our pathway within the patient support core, but also to the UCSF translation and interpreter services, because they can now hold the interpreters accountable for what is being said during those appointments. And so that just goes to show how these interventions, like our notes and the audio recordings, can be tailored to further support this specific patient population, and how our experiences in medicine play an instrumental role in these kinds of solutions.
So our next steps do involve getting feedback from both patients and providers on how we can better make this more efficient. If there's a way to reduce the time, perhaps the time between we get the translated notes or the interpreted versions of the audio recordings. And within the PSC, we do hope to make this more of a part of our routine trainings. And if any of you have any referrals for patients, both English speaking and patients who speak languages other than English, who may benefit from our services, you can give us a call or you can email us. And that's the QR code for our website. Again, we do want to acknowledge our mentor, Jeff Belcora, for his guidance throughout this project, our immigrant families, and the patients who continue to navigate these gaps and piece together their healthcare. So thank you all.
Great way to end our program, and we love the fact that you guys took initiative to provide services that are so important. And there really is very little. I mean, once you're certified as a translator, there is no accountability. You know, I think it's true. You know, people who are not bilingual don't have the opportunity to do that. So having this and having a diverse population of our students, our interns, our providers is so incredibly important. So just in thinking about this, do you think there's a way to maybe highlight, you know, is this maybe something that, you know, we're not able to provide patient support core services for everyone? Perhaps this is a high priority needs population where we should be looking through and identifying people like this to make sure that they're the first to get services. What do you think?
I think we can potentially, this is just an idea, we could potentially leverage AI to start screening for these more high priority individuals based on their socioeconomic circumstances, but also looking at
what about the nurse navigators? They know who these people are.
Yes, we can leverage them too. Right. You're right. Yeah.
So I think we forget, you know, the nurse navigators who start these, you know, I think all, you know, whoever's being sort of the point of contact, you know, is really, I think all of us need to work much more closely So Jean Ann Donnell is moving on, and our new person, I keep forgetting her name, Rita, what's her name? Our new nurse navigator. Charisse. Yeah. So I think, in fact, we should go try and find Charisse. Francesca, find Charisse, see if she wants to come to dinner tonight. Okay. I think that would be, did she just walk out? Yeah. Okay, good. Because I think this is actually one of the keys. So many of our initiatives depend on being able to coordinate with the planning. So I think that's I think it's really important. And so there's nothing, it's not like we don't know. There's a screen already. There's already a screen in Epic
And
that's like,
Epic
right? And there's already does that, right?
Epic already highlights who's going to need an interpreter. And so
And what their socioeconomic status is, right? So we do that. We just have to use it. And so we have to work with the nurse navigators, right? To highlight these people and make sure that Claudia and Charisse and everybody knows and Aldan know that the service is available, right? I think it's really incredibly valuable. Laura.
I just want to mention it's a little different, but you're aware of this program called Patient Counts, which is specifically for Asian background patients. It's very different. It's not describing, but it's for additional help. So that I think that should be in the mix too.
Right.
Because it's a really dedicated group of women helping those patients.
And then there's another thing, which is our virtual, and we heard from Maya at the beginning, there's the virtual informed consent. We're piloting it in iSpy, but it's, it's having this kind of it's a bot. It's Vicky, the bot is, and with little bits of pieces in there that you have and that's interpreted, that actually, the one thing about that is it can be translated into, they think they have up to 120 languages. So you can send that out. So that makes clinical trials all of a sudden infinitely more accessible to people. It's a complex trial to start with, but I think this is the kind of thing that, we were fighting over, the advocates didn't like the sound of the bot voice, but the problem is if you don't do that, then you can't translate into multiple languages. So, we're going to see. I think these are all services that we want to put together. And I think, it's a good thing you're going to be here to carry this on, which is great. And I think that I hope everyone gets the idea that there's all of these programs and all of these projects are so incredibly interrelated, right? And even when you're coming in and you're serving someone, you can say, oh, I know, I can connect you with so-and-so, or I'm the coordinator for that, or you see how everything's coordinated. And that these translator services and that support doesn't stop. But I think it's good. There was once a project that, remember the IDEO people said that we should really make like a treasure map on an iPad of all the different services that we have to try and help people connect right at the beginning. And we were going to do that as an intern group. That was right before COVID. It's a good time to resume since we're out of COVID mode. In fact, even though people are still getting COVID, I shouldn't say that, but we're out of the fear of COVID mode. But and I think that's one of the joys of everyone coming in and working together and getting to know each other better and finding more of those connections. The more connections we find, the more rich our program will be and everyone's experiences will be. Let's give a huge round of applause to everybody. I am so impressed with everyone's presentation. I'm looking forward to our hello goodbye dinner tonight and sending you off. We have our first intern hike tomorrow morning. We're going to do the cross city walk or up until 1 or 2 or something. But anyway, again, so excited to see how wonderfully everyone has done and how much everybody has learned. I learned a lot today, even though it's all stuff I know, because it gives me lots more ideas. Beware. Anyway, welcome to all the new interns. We look forward to seeing everybody tonight at my house, and I will endeavor to get there before you. So a big round of applause to the interns and all the mentors, and thanks for everyone for sticking around. Oh, and another big thanks to Francesca and to Anne Marie. Anne Marie, if you're still there, we're very sad that you also are in COVID quarantine and can't come to the dinner tonight, but we're not letting you go so quickly.
Well, thank you. I want to
She
say a
said,
big,
well done.
yeah,
go
big
ahead.
thank you to all the interns for making me look good as usual. Great job.